The helicopter came out of nowhere, a matte gray Navy aircraft punching through a whiteout blizzard at 11:30 at night, rotors screaming over a hospital that had already lost half its power. It landed sideways in the ambulance bay, nearly clipping a paramedic. Three men in tactical gear hit the ground running before the skids even settled. The one in front didn't stop at the reception desk. He didn't wait for anyone to badge him in. He walked straight into the emergency room, soaking wet, ice in his beard, and said four words that made every person in that hallway go completely still. "Where is Emily Hart?" If you've never seen a hospital full of trained medical professionals go silent all at once, it's a strange thing. One moment there's the usual noise, monitors beeping, someone shouting down a corridor, the wet squeak of gurneys, and then there's nothing, just wind rattling the windows and a Navy captain standing under the emergency lights, with a look on his face that said he hadn't slept in 2 days and wasn't interested in being polite about it. This is the story of the woman they laughed at, the one who got assigned the worst shifts, the pointless paperwork, the tasks that nobody else wanted. The one who smiled and nodded and kept her head down while people with half her experience talked down to her like she was furniture. Most of them never knew why she never snapped back, never knew what she was carrying under those cheap hospital scrubs. They were about to find out. Before we go any further, if you're new here, hit that subscribe button. Every week we bring you stories that will stop you mid-scroll, the kind that make you want to call someone at 2 in the morning just to tell them about it, like this channel. Drop a comment right now and tell me what city or country you're watching from. I've had viewers from places that genuinely shocked me, and I want to see how far this one travels. Now stay with me, because this story doesn't slow down. Harwick Regional Medical Center sat at the edge of Duluth, Minnesota, on a bluff above Lake Superior, and in February it looked exactly like the kind of place where things went quietly wrong. The building was functional rather than impressive, a 7-story block of pale concrete that had been expanded twice in 30 years, each addition slightly uglier than the last. It served a region that stretched across 3 counties and into rural Wisconsin, which meant that on a bad night, it was the only option for a lot of people who had run out of options. Emily Hart had been working there for 11 weeks. She was 29 years old, 5'6", with the kind of face that people described as pleasant and then immediately forgot. Brown hair she kept in a regulation bun. Calm gray eyes that didn't give much away. She moved through the ER the way water moves, efficiently, without drawing attention, filling whatever space needed to be filled. On paper, she was a second-year ER nurse who had transferred from a smaller facility downstate. She had excellent references, a clean record, and a manner so unobtrusive that several of the attending physicians had walked past her for 3 weeks before learning her name. The nurses who had been there longer noticed her for different reasons. Sandra Polk had worked the Harwick ER for 11 years and had developed the specific talent of identifying new staff within their first 2 weeks and sorting them into categories. The ones who would last, the ones who wouldn't, and the ones she could use. Emily had landed in a 4th category that Sandra rarely encountered, the ones she couldn't quite read, and that bothered her in a way she didn't examine too carefully. So she did what she usually did when something bothered her. She made it smaller. Emily was assigned the intake paperwork that nobody wanted. She was asked to restock supply rooms that had already been restocked. She was handed double shifts that appeared on the schedule without explanation and disappeared when challenged, replaced by single shifts in the least desirable rotation. Sandra did all of this with a kind of cheerful efficiency that made it very difficult to object to, and Emily accepted each task with the same expression, a small nod, a quiet, sure, that Sandra found either admirable or suspicious, depending on her mood. The physician who set the tone for the attending staff was Dr. Garrett Lowe, a trauma surgeon who had been recruited from a university hospital in Chicago 3 years earlier and had not entirely forgiven Duluth for not being Chicago. He was technically excellent and interpersonally careless in the way that some technically excellent people allowed themselves to be. He knew it. He had once described his own bedside manner as honest, which was the word people used when they didn't want to say unkind. He had said approximately 40 words directly to Emily in 11 weeks. Most of them were corrections. Hart, lidocaine goes on the left side of the tray. Hart, if I ask for a pressure reading, I need it in 5 seconds, not 15. Hart, this isn't complicated. She took the corrections without expression, adjusted, and moved on. That bothered him too, though he wouldn't have admitted it. The ER staff had a shorthand for her that started as a joke in the break room and calcified into something unkind. The ghost. She was there, she did her work, she didn't register. It was meant to describe her quietness, and ended up describing the way people looked through her. None of them knew what she had been before she became this. The morning of February 11th started with a fight in the parking garage. Two guys who had driven there from a bar 40 minutes away, one of them with a broken hand that he'd made worse by hitting the other one with it. Emily triaged them both, separated them before either could make things worse, and had the one with the hand in radiology within 12 minutes. Sandra watched this from the nurse's station and said nothing, which was its own kind of comment. By 8 in the morning, the ER had 7 patients, a chest pain admission, 2 flu cases that should have gone to urgent care, a teenage kid with a skateboard injury that was going to turn into a fracture once the swelling went down, and a woman in her 60s who had come in with her daughter insisting her arm hurt differently than normal, and turned out to be presenting a lateral wall MI that Emily flagged before the first EKG was even read. She had flagged it quietly. She had walked up to Dr. Lowe, waited for him to finish what he was doing, and said, "Mrs. Halverson in Bay 4. I think we need to bump her up. Her pain description doesn't match musculoskeletal, and she's got subtle diaphoresis she didn't mention on intake." Lowe had looked at her for a moment in a way that suggested he was performing a rapid calculation about whether to argue. "Pull a troponin and a 12 lead, he said, and walked away. The troponin came back elevated. The 12 lead confirmed it. Mrs. Halverson went to the cath lab within an hour and had a 90% occlusion in her RCA that the interventional cardiologist described afterward as a textbook widowmaker caught early. Nobody specifically said Emily had caught it. Nobody specifically said she hadn't. The case moved through the system and the morning continued, and Emily went back to her intake paperwork. Sandra, at the nurse's station, watched her sit down and pull out the forms, and something crossed her expression that she smoothed away before anyone could identify it. The construction worker came in at 11:47. His name was Ricky Duarte, 36, a concrete crew foreman from a job site out on Miller Road where they were putting up a new distribution center. The job site had been working through the cold snap because the pour schedule couldn't slip, and Ricky had been on the elevated formwork when something gave way, a support strut that was supposed to be braced and wasn't, and he had come down 12 feet onto a concrete floor with a load of equipment coming down after him. He arrived by ambulance, and the paramedics were already moving when they came through the doors. GCS 14 on scene dropped to 12 in transport. BP's been unstable, 90/60 on the last read, bounced up to 106, back down. Mechanisms a 12-foot fall with secondary crush. Obvious rib fractures on the left, possible pelvis involvement. He was conscious on scene, but he's getting foggy. Dr. Lowe was already gloving up. The trauma bay opened up around Ricky Duarte like a well-rehearsed piece of theater. Nurses on either side, respiratory at the head, the controlled chaos that looked like chaos and wasn't. Emily was on his left side. She had her hands on him before he was fully transferred to the trauma bed, not because she was supposed to be the one doing it, but because she was there and he needed it. Assessment. She was already running it. The rhythm of it was so deeply built into her that it happened below the level of conscious thought. His abdomen was guarded on the left. Not dramatically. He wasn't screaming, but there was a tension there that wasn't right, a rigidity that didn't match the rest of his presentation. His breathing was also off in a way that was easy to miss if you were looking at his vitals and not at him. The left side of his chest was moving slightly less than the right. Not a lot. Enough. She looked at his face. He was pale in a specific way. Not the gray of shock, not yet, but the white of someone whose body was spending everything it had just to keep the main systems running. His eyes were tracking, but slow. She had seen this before. She had seen it in places where there was no hospital anywhere within driving distance, and the decision you made in the next 4 minutes was the only decision that was going to matter. Dr. Lowe, she kept her voice even. I think he may have a tension component on the left. The chest wall movement is asymmetric, and his pressure drops don't fit the obvious injuries alone. Lowe was focused on the rib fractures, calling for imaging. We'll get the chest film. The pressure's not waiting for a film. He looked up at her. There was a specific quality to the look, the kind that said, I don't remember asking you. But she held the eye contact because she had read something in Ricky Duarte's vitals that she was not going to walk away from. His trachea is slightly deviated, she said. I need you to check before we image. The word deviated landed differently. Lowe set down what he was holding. He stepped to the head of the bed, tilted Ricky's chin, looked, and then his hands went to the man's neck with a focus that hadn't been there 30 seconds ago. He didn't say she was right. He called for the needle. The decompression confirmed it. A tension pneumothorax that hadn't fully declared itself yet, which was the worst kind. The kind that killed people in the gap between not obvious and too late. Once the pressure released, Ricky's oxygen saturation came up 9 points in under a minute. Sandra, who had been at the back of the trauma bay, looked at Emily with an expression that she covered quickly with something that wasn't quite neutrality. Lowe, for his part, said nothing directly to Emily. He moved on to the next phase of assessment, called for the abdominal ultrasound, and managed the rest of the trauma with the focused intensity he brought to everything. The team worked around him. Emily stepped back to her position and continued monitoring. Later, at the nurse's station, she was entering her documentation when Sandra appeared behind her. Dr. Lowe runs his trauma bays a certain way, Sandra said. Her voice was pleasant. It was always pleasant. He's got a system, and the system works. New staff sometimes mistakes reading about something for knowing about something. Emily finished typing a line before she responded. Is there something you need me to fix in my documentation? That's not the point I'm making. Then I'm not sure I understand the point. Sandra held her eyes for a moment. The point is that in this ER, we support the attending's decisions. We don't second guess in the middle of a trauma. He checked. He agreed. He would have checked regardless. Emily looked at her. She had nothing to add to that, and Sandra could see it, which seemed to bother her more than an argument would have. You're on supply inventory this afternoon, Sandra said, and walked away. What? She did the inventory. She counted IV bags and saline flushes and box after box of nitrile gloves, and she documented everything exactly as she was supposed to. And at 3 p.m, she sat in the break room for 12 minutes and ate a sandwich she'd brought from home and looked out the window at the lake. Lake Superior in February was a specific kind of brutal. The near shore was iced over, but the main lake was dark and moving, and when the wind came off it, the temperature dropped fast enough to feel physical. The forecast for the next 48 hours was the kind that made people in Duluth, people who were used to this, genuinely quiet. Emily looked at the lake and thought about nothing in particular, which was something she had gotten good at. The ability to simply not think, to sit in a moment without it meaning anything. That had taken her years to develop, and she valued it the way other people valued sleep. Her dog tags were under her scrubs. She wore them out of habit rather than sentiment. They had been there so long that not wearing them would have felt like forgetting something. She didn't think about what they represented. She didn't not think about it either. They were just there. She finished her sandwich, folded the bag, put it in her pocket, and went back to work. The ER picked up again around 4, the way it always did when the day shift started turning into evening, and people who had been managing their pain or ignoring their symptoms since morning finally gave up and came in. A kid with an allergic reaction, a woman whose blood pressure was so elevated her vision had gone blurry. 2 frostbite cases from a construction crew that had been working outside in conditions that shouldn't have had anyone working outside. Emily was moving between them when she saw Sandra stop Dr. Lowe near the physician's corridor. She wasn't trying to listen. She was 12 feet away, and the ER had quieted enough that she couldn't not hear. Been keeping an eye on her, Sandra was saying. She's got a confidence problem. Gets in the middle of things that aren't her call. She flagged the pneumo, Lowe said. Not defending Emily, just stating a fact. One catch. She also interrupted your initial assessment, talked over your orders twice that I saw, and 3 other nurses have mentioned she makes them feel like they're doing things wrong. It's a culture issue. A pause. Talk to her, Lowe said. If it keeps up, document it. I'll handle it. Emily went back to her frostbite patient, checked his rewarm protocol, adjusted his blanket positioning, and said nothing. Her face didn't change. Her hands were steady. She had heard worse things said about her in worse places. She had heard them said about her when lives depended on what came next, and she had made the right calls anyway. She was going to make them here too. What happened next started at 5:47 with a sound. The ER had a particular acoustic quality, a specific ambient hum of equipment, and movement and voices that everyone who worked there tuned out. Emily had been tuning it out for 11 weeks. But sound was something she had been trained to notice in a different context, in environments where the wrong sound at the wrong moment was information you couldn't afford to miss. The sound at 5:47 was an intake of breath from the triage nurse, Alicia, followed almost immediately by 2 words into the radio. "We've got multiples." The report came in fragments, the way mass casualty reports always did. A section of Highway 61 north of the city, a stretch that ran along the lake bluff, had turned into ice during a temperature drop faster than the road crews had caught. 7 vehicles at minimum. The initial call came from a trucker who had stopped to help. He was trying to describe what he saw and kept stopping himself. Then the second part came through. One of the vehicles was a chemical transport. The trucker wasn't sure what it was carrying, only that there was a smell and a color to the air that was making his eyes water, and he had moved away from it. Alicia put down the radio and looked across the ER. Lowe was already at the charge desk. He pulled up the hospital's mass casualty protocol on the wall screen, a laminated chart that most of the staff had never needed to reference in a real event. Sandra was next to him, pulling her phone out, calling someone. Emily stood near Bay 3, watching. She calculated. Highway 61 in these conditions. First ambulance, 12 minutes minimum, probably 15. More if the road was as bad as the trucker's voice suggested. Unknown number of victims. Chemical exposure of undetermined type, eyes watering and color in the air narrowed it to halogenated compounds, possibly chlorine-based or industrial solvent, but she couldn't be certain. Respiratory cases incoming alongside trauma. That was a specific combination that required specific preparation that she had done before, in a context that nobody in this room knew about. She went to Dr. Lowe. "We should set up the negative pressure room in 6 for respiratory cases before they come in," she said. "If it's a halogenated spill, we're going to have airway compromise come through the door. We want them separated from the trauma intake." He looked at her. She could see him calculating something that wasn't medical. "We follow the MCI protocol," he said. "The protocol doesn't account for a combined trauma chemical event. We need to adapt." "Hart." His voice dropped just enough to be a boundary marker. "We run the protocol." She stopped. She had hit the wall that she had been hitting for 11 weeks, and she understood it exactly for what it was. Not medical disagreement, but a power structure that had decided what she was and was not going to be allowed to be. She could push through it right now. She knew what she knew. But she also understood that if she pushed, and the medical director agreed with Lowe, and she got pulled from the floor during an incoming mass casualty event, she would help no one. She stepped back. She went to Alicia's station and asked quietly if she could pull up the respiratory isolation room availability on the secondary terminal. Alicia looked at her for half a second, then nodded and pulled it up without asking why. The first ambulance bay doors opened at 6:03. The first patient had chemical burns across his arms and face and was conscious but barely, screaming at a pitch that cut through every other sound in the room. The second was a woman who wasn't screaming, who was making a sound instead that Emily recognized before she was through the door, a high-pitched crowing wheeze that meant her airway was losing the argument with whatever she had inhaled. The woman's name, Emily would learn later, was Petra Voss, 41 years old, a teacher who had been driving home from a parent conference. Right now she was a set of vital signs and a set of sounds, and the sounds were the problem. Lowe moved to her immediately. He called for intubation equipment. He positioned himself, laryngoscope in hand, and looked. He looked again. Emily was 2 feet away. She could see what he was seeing, which was nothing. The airway was swollen to a degree that made visualization impossible, the edema moving fast in a way that was characteristic of a specific type of chemical exposure, and the window for a standard intubation was closing in real time. Lowe pulled the scope out. He called for a smaller blade. He repositioned. Petra's oxygen saturation read 68%. The monitor alarm had been screaming for 20 seconds. He pulled the scope out again. "I can't visualize," he said, to nobody specifically, to the room. Emily was already moving. She didn't ask permission. There wasn't time for the question, and there certainly wasn't time for the argument that would follow the question. She stepped around the head of the bed, picked up the surgical airway kit that she had quietly confirmed was in Bay 6 when the MCI report came in, and looked at Lowe. "I need you to step back." He stared at her. "I can't," he said. meaning the intubation, meaning he hadn't been able to do it. "I know," she said. "Step back." He did. She didn't look at his face. She opened the kit. What she did next took 97 seconds. She knew because she counted automatically, the way she had been taught to count in environments where time was the only resource you had full control of. A surgical cricothyrotomy, a cut through the neck into the airway, a tube placed directly, bypassing the obstruction that was going to kill Petra Voss in the next 2 minutes if someone didn't bypass it. It was not technically a nursing procedure. She had performed it 7 times before in her life. None of those times had been in a hospital. When she secured the tube and bagged it, and Petra's saturation started climbing, 68 to 74 to 81, moving, recovering. The trauma bay went quiet for a moment that felt longer than it was. Then the next ambulance hit the doors. And the next. Emily straightened up, looked at the room, at the beds, the staff positions, the available equipment, the bottlenecks she could already see forming, and something shifted in her that she had been holding very carefully in check for 11 weeks. She raised her voice, not loudly, but in a way that carried. "We need to restructure. Trauma to bays 1 through 4, respiratory isolation to 5 and 6, chemical burns to the corridor staging area. I need someone on family notification at the waiting room door and someone dedicated to the radio. Low, can you take primary on the traumatic injuries if I manage the airway and chemical cases?" Nobody moved for a moment. Sandra was staring at her. Low was staring at her. Then one of the paramedics, a heavy-set guy named Marcus, who had worked Duluth EMS for 8 years, said that actually makes sense and moved to Bay 1. And then the room moved with her. She didn't smile. She didn't register it at all. There was too much work. By 6:30, they had processed 11 patients. By 7:17, Emily was in Bay 6 with a man whose lungs were losing fluid faster than anyone was comfortable with. Adjusting his positioning and his oxygen parameters while calling orders, she was technically not authorized to call to a respiratory therapist who had stopped checking whether she was authorized and was simply following the logic of what she said, because the logic was correct, and the patient was improving. Sandra appeared in the doorway. "You need to come to the charge desk. I'm in the middle of something. Now, Emily." She handed off to the respiratory therapist with specific instructions and followed Sandra to the charge desk. Lowe was there. He had a look on his face that she hadn't seen from him before. Not angry, exactly. Something more complicated. "What you did in Bay 2, he said. She was dying. You performed a surgical procedure. She was going to die in 60 seconds. That's not the point. With respect," Emily said, "that is exactly the point." Silence. Then Sandra, with her tone of reasonable concern, "We can't have nurses deciding unilaterally to perform surgical procedures, regardless of the outcome. There's a liability and protocol issue here that 17 patients stabilized," Emily said. "How many have we lost?" Sandra blinked. "That's not how we evaluate." "0, Emily said. "We've lost 0, which is what I'm going to keep working toward. So tell me what you need from me. Documentation, a verbal report, a formal review, and I'll give you all of it. Right now I need to go back to Bay 6. She walked away. She heard Sandra say something behind her. She didn't stop. At 8:15, the power went out. Not all of it. The generator caught within 4 seconds, the way it was supposed to. But 4 seconds is a long time in a room full of critically ill people. And the transition from full power to emergency lighting changed the texture of everything. The ER went from clinical fluorescent white to a dimmer amber, and the sound changed, and people who had been functional became suddenly frightened. Emily was at the nurse's station when it happened. She didn't freeze. She counted the 4 seconds, confirmed the generator had kicked in, identified the 3 patients most likely to be destabilized by the interruption, and moved. Outside, through the ER windows, the snow had gotten worse. The parking lot lights caught the blizzard at an angle that made it look almost solid, a wall of white moving sideways. Somewhere in that wall, another ambulance was trying to get through. Alicia, at the triage desk, suddenly stood up. She was listening to her radio. Her face had changed. "What is it?" Emily said. Alicia looked at her, then she looked at the windows. "There's something coming," she said. They're saying to clear the ambulance bay. They're saying it's military." The sound reached them before they could see anything. A deep, rhythmic percussion that cut through the blizzard and through the walls and through everything, the sound of a rotor-driven aircraft moving fast and low. The kind of sound that didn't belong over a civilian hospital. The kind of sound that Emily Hart had spent years of her life learning to track by ear. Every light in the ambulance bay swung violently to the left as something massive came in low over the roof. Emily stood very still. She put her hand over her sternum, over the place where the dog tag sat under her scrubs, not as a gesture, but as a reflex. An old one, deeply seated. Her jaw tightened. The aircraft hit the ambulance bay with a force that shook the windows. And then the ER doors opened, and the man who came through them, soaking wet, ice in his beard, moving like he had been moving fast for a very long time, stopped in the middle of the room and said 4 words. "Where is Emily Hart?" Nobody answered him. That was the thing that struck Emily first. Not the man himself, not the aircraft still shuddering outside, not even the fact that 3 armed men had just walked into a civilian emergency room during an active mass casualty event. It was the silence. 17 staff members in that ER, nurses and techs and paramedics, and a trauma surgeon who had an opinion about everything, and not one of them said a word. They just looked at the man in the doorway, and then they looked at each other, and then they looked at the floor, because there was something in the way he held himself that made looking directly at him feel like standing too close to something with a lot of voltage. He was maybe 50, built the way people got built when their body had been a tool for a long time, and they had taken reasonable care of it. His uniform was navy, flight suit over tactical layers, rank insignia that Emily clocked in the first second without meaning to. Captain. The 2 men behind him were younger, quieter, positioned in the way that people positioned themselves when they had trained for rooms they didn't know yet. "Where is Emily Hart?" he said again. Sandra found her voice first. "I'm the charge nurse. Can I ask what this is?" "I didn't ask for the charge nurse. I wasn't rude about it. That was almost worse. He said it the way you said that's not what I ordered at a restaurant. Factual, final, moving on." "Emily Hart. She's listed as staff here. I need her in the next 3 minutes." Lowe stepped forward. Emily could see him deciding to be the authority in the room, which was something he was usually good at. "This is an active mass casualty event," Lowe said. "We have critically ill patients. Whatever you need, I'm the attending on—" "Doctor." The captain looked at him. "I've got a man in that aircraft who is going to die before we can get him to Bethesda if I don't find someone in the next 3 minutes who I know can keep him alive. I was told Emily Hart works in this building, so I'm going to ask one more time." Emily said, "I'm here." She had been standing 6 feet to the left of the nurse's station, not hiding exactly, but not moving either, held in place by something she couldn't have named precisely, a specific weight in her chest that she recognized from a long time ago. The kind of weight that settled in when a situation stopped being theoretical. The captain turned. He looked at her. Not the assessing look that people gave strangers, but the look of someone locating something they had been searching for. His eyes moved across her face the way you read a document you already know the contents of, checking to make sure nothing had changed. Then he said, "Chief Hart." Not Nurse Hart. Not Ms. Hart. He used her rank. The rank she hadn't held in 3 years, attached to the name she'd had when she was a different version of herself in a different version of her life. He said it the way you said it on a base, 2 words with a specific weight between them, and the effect in the room was immediate and strange. Like a tuning fork struck in a space where everything had been slightly out of tune. Sandra made a sound. Not words, just a sound. "I need 5 seconds, Emily said to the captain. He nodded. She turned to the respiratory therapist, a young guy named Troy who had been following her instructions for the last hour, without asking why, and said, "Mr. Darnell in 6 needs his PEEP adjusted if his SAT is dropped below 92. Don't wait for an order, just do it and document after." Troy nodded. She looked at Alicia. "The patient in Bay 3 is going to start complaining about his pain level in about 20 minutes. He's not wrong. Get Lowe to sign off on a bump to his morphine before that happens." Alicia wrote it down. Then she picked up her trauma scissors, her pen light, and the small kit she kept in her left pocket, and she walked toward the captain. Lowe said, "Hart, you're in the middle of a shift." She stopped, turned. "You've got this," she said, and meant it. Not sarcasm, not a dig. He did have it. He was a good surgeon when he wasn't being an obstacle, and the worst of the incoming wave had been processed, and the remaining cases were within his capability. She had spent the last 2 hours making sure of that. He didn't have an answer for that. She walked out. The cold hit her like a wall. She had been inside since 6 that morning, and she had forgotten, in the specific way that happens when you're inside doing urgent things for hours, that the outside world existed at all. The wind came off the lake at an angle and carried ice crystals that weren't quite snow. They were finer than that, harder, the kind that got into the gaps between your collar and your neck, and didn't feel cold so much as sharp. The aircraft in the ambulance bay was a modified Navy MH-60, the kind that had been adapted for special operations medical transport. And even now, rotors spinning down but not stopped. It took up most of the cleared space and left the ambulance bay feeling like the inside of a box with something too large in it. The third operative, she hadn't caught his face inside, was standing at the aircraft's side door with his back to the wind, and he stepped aside when the captain approached. "What happened?" Emily said. "Military convoy was on 61 when the pileup hit. We had 3 vehicles involved, 2 walking wounded, 1 critical." The captain was moving as he talked, not looking at her, his eyes on the aircraft door. "Commander Joel Rask, 44. He was in the lead vehicle when it took a secondary impact from the tanker side collision. By the time we got to him, he had a penetrating chest injury, rebar, went in low and lateral. We pulled it out because we had to move him." Emily's stomach tightened. "You pulled it?" "We didn't have a choice. He was pinned, and the vehicle was compromised." She knew what that meant. Penetrating chest trauma, implement removed in the field. The implement itself had been doing a portion of the work of containing the bleeding. Without it, the bleeding was now contained by nothing except whatever the body could do on its own, which in this case was clearly not enough, because otherwise they wouldn't be here. She climbed into the aircraft. The interior was dim, lit by 2 small panel lights, and the hand held low had aimed at the patient. Commander Joel Rask was strapped to the litter with the specific tightness of someone who had been secured by people who understood that turbulence and a critical patient were a dangerous combination. He was big, 6'2" at least, broad across the shoulders, the build of someone who had spent decades doing physical work. Right now he looked like someone who had spent the last hour bleeding. His face was the color of old paper. His breathing was the thing she fixed on immediately, shallow, labored, with a quality that she could hear before she even put her hands on him. The kind of breathing that happened when the pleural space was compromised, when the mechanics of the chest wall had been interrupted and the body was working 3 times as hard to move half as much air. She put her hands on him. Left lateral chest. The entry wound was covered with a field dressing, pressure applied, the dressing dark and wet through. She pressed carefully around the margins, and Rask's jaw tightened, a sound escaping him that he clearly didn't want to make. His pressure, on the portable monitor clipped to the litter rail, read 84/50, 84/50 and dropping. "How long since the injury?" she said. 51 minutes, the captain said. He was in the doorway behind her. He didn't offer opinions. She appreciated that. "What do you have on board?" "Full TCCC kit. 2 units packed cells, 1 FFP. Thoracic needle kit. We've got a portable suction." She was already running the assessment, hands moving with the economy of someone who had done this when the stakes were higher and the resources were worse. The bleeding from the wound site was controlled but not resolved. The field dressing was doing its job, but the job was too big for a field dressing. Beneath that, her concern was the cavity itself. With a penetrating lateral injury at that depth, the pericardium was in play. She pressed 2 fingers to his neck, feeling for the venous distension that would tell her whether fluid was building around the heart. It was there. Faint, but there. "He's developing a tamponade," she said. The captain said nothing. He'd known, she thought. That was why he'd come. "I can't fully manage this in the aircraft," she said. "I need a stable surface, more light, and access to a surgical airway setup in case his pressure goes out completely during the procedure. Can you get him inside?" "That's why we're here," the captain said. Getting Commander Rask out of the aircraft and into the hospital took 4 minutes and involved a level of coordinated physical effort that Emily did not have time to appreciate. The 2 operatives moved him with the practiced efficiency of people who had moved injured men in bad conditions before, and the captain held the portable monitor and kept his mouth shut, which was exactly what she needed from him. They came through the ambulance bay doors and back into the ER, and the effect was immediate. Sandra was at the nurse's station. She saw the litter, she saw the military personnel, and she started moving toward them with the expression of someone about to manage a situation. "We don't have a bed cleared for Bay 2, Emily said without looking at her. "It was discharged 20 minutes ago." "I know what was discharged, but the protocol for receiving military—" "Sandra." Emily stopped. She turned and looked at her, and something in her face, not anger, but the complete absence of the careful neutrality she usually maintained, made Sandra stop talking. "There is a man on this litter who is going to die in the next 30 to 40 minutes without a specific intervention. I need Bay 2 cleared and lit. I need a thoracic tray. And I need you to call whoever you need to call. Do all of that in that order." She didn't wait for a response. She pushed the litter toward Bay 2. Behind her, she heard Sandra on the phone. Whether it was the administrator or the chief of staff or the security desk, she didn't know and didn't care. Lowe appeared from Bay 4. He saw the litter. He saw the captain. His expression moved through several things quickly. "What is this?" "Cardiac tamponade, penetrating chest trauma, 53 minutes post-injury." Emily was already at the cabinet, pulling what she needed. "I'm going to do a pericardiocentesis. If the pressure holds, that buys us time for transfer to a surgical center. If it doesn't hold, we're looking at a pericardial window, and I need you to be in the room." "You're going to do a—" Lowe stopped. He looked at the captain. "Who authorized this?" The captain looked at him with a patience that wasn't comfortable. "Her," he said. "She's a nurse." "Captain Marcus Webb," the captain said, and he said it the way you said a name when the name was supposed to end the conversation. "I'm the senior officer in this facility right now. Chief Hart has performed this procedure under combat conditions. You can verify her record through the Naval Special Warfare Medical Command after we keep this man alive." Lowe looked at Emily. She was setting up the tray. Her hands were moving. She wasn't looking at him. "I need you in the room or I need you out of it," she said. "Pick one." The silence lasted 3 seconds. Then Lowe pulled on a glove. The pericardiocentesis was not elegant. She wanted to be clear about that in her own mind because the versions of this procedure that got taught in controlled environments with ultrasound guidance and a team of people with specific roles and no one bleeding out on the table, those looked different from this. What she was doing now was guided by her hands and her training and 15 years of accumulated physical memory in a room lit by emergency power with a monitor that kept alarming in a way that told her she didn't have as long as she wanted. She inserted the needle at the subxiphoid angle, 22 degrees, advancing slowly, watching the monitor trace, feeling for the specific change in resistance that told her she was in the pericardial space, and not the myocardium. It was a distinction that mattered enormously. It was a distinction you learned to feel before you learned to trust what you felt, and then you practiced until feeling and trusting happened at the same time. Rask was conscious. That was both good and bad. Good because his pressure hadn't dropped to the point of unconsciousness. Bad because being conscious while someone put a needle into your chest was an experience that required a specific type of patient cooperation that couldn't be guaranteed. "Stay still," she said to him. Not unkindly, just clearly. "Trying," he said through his teeth. "I know, keep trying." The resistance changed. She was in. She aspirated. Dark blood came back, non-pulsatile, the specific dark red of pericardial effusion rather than the brighter arterial blood that would mean she'd hit the wrong thing. She withdrew fluid. 60 milliliters, which was more than she had wanted to find and less than she had feared. On the monitor, Rask's pressure moved, 84 to 91. Then 96. She heard Lowe exhale through his nose. She withdrew the needle, dressed the site, and stood up straight for the first time in 4 minutes. Her lower back registered a complaint that she filed and ignored. "His pressure's holding," Troy said from the monitor. He had followed them in, which she had not asked him to do and was not unhappy about. "For now," she said. "He needs a surgical repair. This bought time, not a solution." She looked at Captain Webb. He was standing against the far wall, arms at his sides, watching with the look of someone who had decided to trust something completely and was waiting to find out if that had been the right decision. "He needs transport to a level 1 center," she said. "How's your weather window?" "We've got maybe 90 minutes before the ceiling drops to 0. After that, we're grounded until morning." She looked at the monitor. Rask's pressure was holding at 98/64. His breathing was easier. The tamponade relief had taken some of the load off. He wasn't stable, but he was more stable than he had been, and more stable was the only unit of measurement that mattered right now. "Prep him for transport," she said. "I want 2 large-bore IVs running, both units of packed cells going before you load him. Keep him in 30-degree elevation, not flat. If his pressure drops below 80 in flight, you needle the same angle again. I'll write it down." "You're not coming?" Webb said. She looked at him. Behind her, she was aware of the ER, of the 17 patients in various stages of treatment, of Troy at the monitor, of Alicia at the desk, of Lowe standing with his gloves still on and an expression she hadn't seen from him before. Outside, the blizzard had reached a pitch that made the windows sound like they were being worked on. The highway was still producing casualties. She had people here who needed her. "I can't leave," she said. Webb nodded once. He understood operational priorities. "I'll need someone to ride with him," he said. "One of my men can manage the physical transfer, but we need a medical—" "Alicia can give you a paramedic from the standby crew," Emily said. "They've been waiting since the first wave." She turned to Alicia, who had appeared in the doorway. "Kepler? He's FPC certified?" "Yeah," Alicia said. "He's in the break room." "Get him." Things moved. That was the thing about decisions made with clarity. They created their own momentum, pulled other people into the current, turned a room full of hesitation into a room full of directed motion. Within 6 minutes, Commander Rask was prepared for transport. The paramedic named Kepler had been briefed and was already in his coat, and the 2 operatives had the litter in motion toward the ambulance bay. Captain Webb paused at the bay door. He looked back at Emily. "I'm going to make a call when we land," he said. She didn't ask what kind of call. She had a sense of what kind of call it was, and she had a sense of what it would mean, and she pushed both of those things into a box that she didn't have time to open right now. "Get him there," she said. Webb went out into the blizzard. The ER at 9:15 looked different from the ER at 6. It was the same room, same bays, same equipment, same amber emergency lighting with the overhead fluorescents. Supplemented by portable work lights someone had pulled from a supply closet. But it had the quality of a room that had been through something, the slight disorder and improvised organization of a space that had been pressed past its normal function and had adapted rather than collapsed. Supply wrappers on the floor that nobody had gotten to yet. A whiteboard with patient names in 4 different handwriting styles. Bay curtains pulled at angles that weren't their designed angles because the designed angles hadn't been what the situation needed. Emily was at the nurse's station, updating documentation with the focused mechanicalness of someone who understood that the record of what had happened was going to matter later. Her hands were steady. Her back still hurt. She had a small laceration on her left index finger from a tray edge that she hadn't noticed until the adrenaline started to metabolize, and she had taped it with a strip of cloth tape from her pocket kit, and that was sufficient. She was aware, without looking, of Sandra at the far end of the station. Sandra had been on the phone twice in the last 20 minutes. The second call had lasted 11 minutes, which was too long for a normal administrative update. Emily documented and did not think about what that meant. Lowe came out of Bay 4. He stood near the station for a moment without saying anything, which was unusual for him. Then he said, "The tamponade call." Emily kept typing. "I didn't see it." "You were working on the rib frac in 3. You were occupied." "I would have seen it eventually." She stopped typing. She looked at him. He had the look of a person choosing between 2 versions of a sentence, and she waited while he chose. "You were right to move when you did," he said. It came out slightly compressed, like a word that had been run through a small space. But it came out. "Okay," she said. He nodded. He went back to Bay 4. She went back to her documentation. Alicia appeared beside her. "I've got something on the radio," she said, keeping her voice low. "There's a second convoy vehicle they're still working on. Off the road, down the embankment near mile marker 32. They've got 2 more injured. 1 ambulatory, 1 is a bad extraction. ETA here is at least 30 minutes because of how they have to bring him up the bank." Emily processed this. 1 ambulatory she wasn't worried about. The other, bad extraction, was a phrase with specific implications regarding mechanism and duration. "What's the weather doing?" "Getting worse. They're saying visibility is under a quarter mile on 61. Emily looked at the window. The blizzard pressed against the glass like it had intentions. The ambulance bay lights, what was left of them, caught the snow at an angle that made it look almost horizontal. Okay, she said. She finished the documentation line she was on, saved it, and stood up. She was calculating. She did it the way she always did it. Not consciously, not as a series of steps, but as a kind of continuous background processing that she'd had since before she could have named it. Current patient load, manageable. Staff coverage, adequate. Equipment availability, strained but sufficient. Incoming patient, unknown severity, extraction trauma, minimum 30 minutes. She had 30 minutes. She went to Bay 6 to check on the man with the fluid-overloaded lungs, adjusted his head positioning, checked his output, noted that Troy had in fact adjusted the PEEP when the SATs had dropped, and had documented it exactly as she'd said to. She went to Bay 3 and verified the pain management had been updated. She went to Bay 1 and spent 4 minutes with a woman named Doreen, who had been in the pileup and had a concussion and was frightened and kept asking for her husband. And Emily sat on the edge of the bed and looked at her and said, "We're trying to find him right now. I promise you that's happening." And meant it, and went to find Alicia to make sure it was actually happening. It was. Alicia had already flagged the family liaison. She came back to the nurse's station and found Sandra waiting. Sandra had a look on her face that was different from her usual expression. The pleasantness was still there, but it was sitting on top of something tight and slightly pale. "I've been talking to Dr. Rowan," Sandra said. Dr. Elliot Rowan was the chief medical officer. Emily had spoken to him once during her onboarding, a brief formal meeting that she had understood to be primarily procedural. He was a careful man. She had gathered that from the way the staff talked about him, from the way decisions flowed through the institution. He was the kind of administrator who moved slowly and was usually right. "Okay," Emily said. "He's going to want a full account of tonight, everything that happened." "That's appropriate." "The procedures you performed, the cricothyrotomy, the pericardiocentesis, are documented." "Emily," Sandra stopped. She recalibrated, started again. "I'm trying to give you a heads up. Rowan is going to have questions about scope of practice, about authorization, about the military personnel, and what exactly transpired in Bay 2. "Good," Emily said. "He should have those questions. I'll answer all of them." Sandra looked at her for a moment with an expression that was trying to find a handhold and not finding one. "You're not worried," Sandra said. It wasn't really a question. Emily understood that. It was an observation, slightly off balance, from a person who had spent 11 weeks building a particular picture of who Emily Hart was and was now watching the picture not match. "I'm tired," Emily said, "and I need to prep for the incoming extraction case. Can we schedule the conversation with Rowan for after the shift?" Sandra opened her mouth, closed it, opened it again. "There's also the question," she said, "of the military captain's statement. He used a specific designation for you, Chief Hart. I don't know what that means, but Rowan is going to ask, and I need to—" "Sandra!" The voice wasn't loud. It wasn't anything dramatic, but it had a quality that made Sandra stop, mid-sentence, the way a particular frequency can interrupt a signal. Emily looked at her directly. "When this shift is over and every patient in this building is stable, I will sit in Rowan's office for as long as he needs me to and answer everything he asks. Right now, I have a critically injured patient coming in from a highway embankment in a blizzard, and I need you to either help me prepare for that or please get out of the way." The words weren't cruel. They were just clear in a way that left no room for anything else. Sandra stood very still. Then she said, "Bay 4 is available," and walked to the phone. The second extraction patient arrived at 9:47. His name was Corporal Damian Ward, 26 years old, one of the convoy's junior personnel. He had been in the third vehicle, which had gone off the road and down a 40-foot embankment, and the extraction had taken the better part of an hour in conditions that the paramedics described with the kind of flat brevity that meant it had been bad enough that elaborating felt unnecessary. He came in with a cervical collar, bilateral leg splints, and a GCS of 13. He was also running a fever. That was the thing Emily noticed before almost anything else. Not high, 38.4, but present, and in context it was wrong. A fever in a patient with multi-system trauma arriving an hour post-injury didn't mean what a fever usually meant. It meant something had been cooking before the crash. It meant there was a baseline that was already compromised. She looked at his hands as they transferred him. The fingertips had a slight dusky quality. Did he report anything before the crash? She said to the paramedic. Any illness? Any complaints? The paramedic, not Kepler, a different one, younger, shook his head. He was talking on scene, said he'd been feeling off for 2 days, thought it was a cold. Did he say where he'd been the past 2 weeks? The paramedic looked at her strangely. No. Emily looked at Lowe, who had come to Bay 4 when the radio announcement came in. I need a sepsis panel, she said. Full cultures, procalcitonin, lactate, and I want a chest film before we do anything else with the legs. The legs are stable for now. The fever isn't. Lowe looked at her for a moment with the expression she was becoming familiar with, the one that was not agreement exactly, but was the absence of disagreement, which was the version she had learned to work with. Pull the labs, he said to Troy. The chest film came back in 8 minutes. Emily was looking at it on the portable reader when the result came in, and she was still looking at it when Lowe came to stand beside her, and then they were both looking at it, and the ER was relatively quiet for a moment. The low hum of equipment, the sound of the blizzard, and nothing else. The film showed bilateral lower lobe infiltrates, subtle but present. Combined with the fever, the timeline, the dusky fingertips, and the oxygen saturation that had been hovering at 94 since arrival. He's got a pneumonia working, Emily said, in a 26-year-old. In a 26-year-old who's been feeling off for 2 days and is now managing it on top of multiple traumatic injuries and an hour of hypothermic exposure. She paused. I want to know where that convoy came from. Lowe looked at her. Why? Because if this is community acquired, we treat it one way. If it's something he picked up in a specific operational environment, we need to know before we treat it, and we need to know before any of our staff gets closer to him than they've already been. The silence lasted 4 seconds. Call the captain, Lowe said. He's in the air. Call whoever you can reach. Emily was already moving to the phone. She had almost reached it when Alicia said from the desk, with a careful neutrality that was doing a lot of work. Emily, there's someone here. She turned, standing at the ambulance bay entrance, not the main ER entrance, but the side door, the one that the staff used when they came in from the parking structure, was a man she didn't recognize. Civilian clothes, expensive, the kind of expensive that looked like it was trying not to look expensive. He was maybe 60, dry despite the storm outside, which meant he'd come through an interior route. He had a badge on a lanyard that she was too far away to read clearly. He was looking at her with the look of someone who had been briefed, and behind him, in the corridor, she could see 2 other people with similar badges and a hospital administrator she recognized, the night shift coordinator, a woman named Peg, whose expression was the specific expression of someone navigating between 2 forces and trying very hard not to get crushed. The man in the expensive clothes said, across the ER, in a voice that carried without being raised, Are you Emily Hart? She held her ground. Yes, she said. He looked at her for a moment. My name is Alan Mercer, he said. I'm with the Department of Defense Inspector General's office. We've been monitoring the convoy's situation since the pileup. He paused. Captain Webb's aircraft landed 20 minutes ago. Commander Rask is in surgery. She felt something release slightly in her chest. She didn't show it. Commander Rask is alive, Mercer continued, because of a procedure performed in this facility approximately 90 minutes ago. He looked at her with an expression that was deliberate and not especially warm, but had nothing of threat in it. We have some questions about what happened here tonight, and I need to ask them before anyone else in this building does. Behind him, in the corridor, Peg was looking at Emily with the desperate expression of someone who did not know what was happening, but was quite sure it was going to require paperwork. Sandra had gone completely still at the nurse's station. Emily looked at Alan Mercer. She looked at his badge, close enough now to read it, confirming what he'd said. She looked at the 2 people behind him who had the flat, calibrated posture of people who wrote reports for a living. Then she looked at Corporal Ward in Bay 4, running a fever and a pneumonia and a set of bilateral leg fractures, with a sepsis panel in the lab and a chest film that was raising questions she hadn't finished asking yet. I have a patient who needs to be managed in the next 20 minutes, she said to Mercer. I'll speak with you after that. He looked at her. Something shifted in his expression. Not surprise, exactly. More like the confirmation of something he'd been told to expect. All right, he said. We'll wait. She turned back to the bay. Sandra, at the station, said nothing. She had the look of someone who had walked into a room expecting to be the most important person in it, and had just understood, with a specific and comprehensive clarity that the math had changed. The monitors in Bay 4 alarmed. Emily moved. Corporal Ward's pressure had dropped, 88/52, and his fever had spiked to 39.1 in the 8 minutes since admission, and his oxygen saturation was sliding south of 92 with a speed that suggested the pneumonia wasn't community-acquired and wasn't interested in waiting. Whatever she had been carrying for 11 weeks, the inventory duty, the break room silence, the 40-word conversations, the accumulated weight of being managed down to nothing, none of it was in the room right now. She was at the bedside. She was working. And in the corridor, a man from the Department of Defense was watching her do it, with a phone in his hand and a call he hadn't made yet, and the knowledge of what Emily Hart's actual record looked like sitting in a file on a server that Sandra Polk had never had clearance to access and never would. The monitor in Bay 4 alarmed again before Emily had fully reached the bedside, a second spike layering on top of the first, and the number on the screen, 86/49, was the kind of number that ended conversations about everything else. Corporal Damian Ward was 26 years old, and he was septic, and the trauma on top of it was the kindling that had turned a smoldering infection into something that was moving fast. "I need a fluid bolus, 500 mils normal saline, wide open," Emily said, not to anyone specifically, to the room, because in the room there were people who could act on it, and the specificity of who didn't matter as much as the speed. Troy was already reaching for the IV line. She put her stethoscope on Ward's chest, left lower lobe, right lower lobe, the crackle of fluid in tissue that shouldn't have fluid in it, and then she pulled it off and looked at his face. He was watching her. His eyes were tracking, which was something. "Damien," she said, "still with me?" "Yeah." His voice was dry, effortful. "What's wrong with me?" "You've got an infection in your lungs that your body's been fighting for a couple days. The crash made everything worse. We're going to get ahead of it." "Am I—" He stopped. Tried again. "Is it bad?" She looked at him directly. She had found, over time, that people in extremis could tell when they were being managed, when the answer they were getting was shaped to protect them rather than inform them, and that being managed felt worse than the truth, even when the truth was difficult. "It's serious," she said. "We're on it." He nodded, closed his eyes. That was enough for him, apparently, which told her something about where he'd been and what he'd already learned to accept. She straightened and lowered her voice. "I need the broad-spectrum coverage started before the cultures come back," she said to Lowe, who had come to stand at the foot of the bed. "Piptazo, and I want Vance on board given his exposure history." "We don't know his exposure history." "Exactly. So we cover wide until we do." She looked at him. "He's been in a military operational environment for at minimum 2 weeks. That's what the paramedic said. 2 weeks of feeling off before a highway crash and an hour in sub-zero temperatures. The infiltrates on his film are bilateral and they're progressing. If this is atypical or drug-resistant, we've already lost ground by waiting." Lowe was quiet for a moment, the kind of quiet that was doing real work. "Get the Piptazo running," he said to Troy. "And call pharmacy for the vancomycin weight-based dosing." Troy moved. Emily was already pulling Ward's chart, looking at the intake vitals compared to the current numbers, drawing a line between them that was going in the wrong direction at a speed she didn't like. His heart rate was 112. His temperature was now 39.3. The fluid bolus was running, but the pressure wasn't responding yet, which meant his vasculature was doing what vasculature did in early septic shock, dilating, pooling, failing to maintain the pressure gradient that kept organs perfused. She looked up at Alan Mercer, who was still in the corridor doorway. "I need the convoy's last 3 postings," she said. "Where they were stationed, what the environmental exposure conditions were, whether any other personnel in the unit have reported similar symptoms." Mercer looked at her for a moment with the expression of someone recalibrating. "That's classified operational. He might be carrying something the rest of my staff has been exposed to for the last 40 minutes, she said. "I need to know whether to put him in isolation, and I need to know now, not after you've made 3 phone calls." Another pause. Mercer reached into his jacket, pulled out his phone, and stepped back into the corridor. Lowe was looking at her again with that expression. "You think it's something specific?" he said. "I think it might be. Legionella, Q fever, something fungal if he was in a construction or demolition environment. Bilateral lower lobe, rapid progression, Relatively young patient who should be handling a respiratory infection better than this. She paused. The duskiness in his fingertips bothered me from the start. That's not typical pneumonia presentation. Peripheral cyanosis could be cold exposure. It could. I'm not betting on it. Lowe said nothing. He put on a fresh glove and did his own assessment of Ward's abdomen, which was the thing she appreciated about him when he was operating at his best. He didn't just accept her findings, he checked. That was correct. That was what should happen. She handed him the pen light without being asked. Ward's pressure, on the next reading, was 91/58. The fluid was working, slowly but working. She exhaled through her nose. Mercer came back in 8 minutes with an expression that had changed. The unit was doing infrastructure assessment in an abandoned industrial site outside Duluth, he said. He kept his voice low, though the bay was relatively private. Old paper mill, decommissioned in the 90s. They were there for 4 days, ended 3 days ago. Emily looked at him. Cooling towers, she said. The site had them, decommissioned but intact. She turned to Lowe. Legionella, she said. Abandoned cooling towers are a primary reservoir. Incubation is 2 to 10 days. He's right on the edge of the window. Lowe was already thinking it through. She could see it. If it's Legionella, Piptazo won't cut it, he said. Tazo won't cut it, he said. No. We need a fluoroquinolone. Levofloxacin, high dose. And I want a urinary antigen test run now. It's the fastest confirmation we're going to get. She was already moving to the supply cabinet, and I need to talk to everyone who's been in close contact with him since he came in. Legionella isn't person to person, Lowe said. I know that, but if he was at the site and symptomatic, there may be others from the unit who were exposed and haven't presented yet. Mercer needs to account for every member of that convoy. She said this loud enough that Mercer heard it. He was already back on his phone. The urinary antigen test was a simple lateral flow, not much different in concept from a pregnancy test, the kind of thing that returned a result in 15 minutes, and was either positive or negative, and left no room for interpretation. Emily ran it herself while Troy set up the levofloxacin infusion, while Lowe updated the chart, while Ward lay in the bed with his eyes closed and his chest moving in the labored cadence of someone whose body was spending most of its energy on a single task. 14 minutes and 50 seconds after she ran the test, she looked at the result. Positive. She stood with the cartridge in her hand for a moment. Not surprised, she had been fairly certain before the result. But confirmation still landed differently than suspicion. Confirmation meant a specific path. Confirmation meant they had been right, and the right treatment was already running, and Damian Ward was going to have a better outcome than he would have had if she hadn't noticed the fingertip color. Confirmed Legionella, she said. Lowe came to look at it. He looked at it for a moment, then looked at her, then looked at Mercer in the doorway. We need to notify public health, Lowe said. Yes, Emily said, and the convoy's commanding officer. Mercer's on it. Lowe set down the cartridge. He pulled off his glove and put it in the waste receptacle and stood for a moment with his hands at his sides. And Emily recognized this as the posture of a man who was making some kind of private accounting. Good catch, he said. It was 2 words. They came out like they cost something, which they did, and she understood that, and she didn't perform anything in response. The levofloxacin will help him, she said. We need to watch his kidney function. Legionella can hit the renal system, and he's already volume depleted from the trauma. She looked at Troy. Hourly urine output monitoring. Flag me if it drops below 30 mils. Got it, Troy said. She walked back to the nurse's station. Sandra was there. She had been there throughout, maintaining her position at the station with the specific stillness of a person who understood that moving would mean making a choice about where to stand, and she hadn't made that choice yet. She looked at Emily. Emily sat down and opened Ward's chart and began documenting the Legionella confirmation, the antigen test result, the treatment adjustment, the public health notification requirements. Her handwriting on the electronic form was clear and complete and included timestamps. She documented everything, including the conversation with Mercer about the industrial site, including her clinical reasoning for the broad-spectrum coverage shift, including the fingertip observation at intake that had initiated the sepsis workup. Sandra watched her type. Rowan is coming in, Sandra said. Tonight. He was already on his way before Mercer arrived. Emily kept typing. Okay. This has gotten larger than a scope of practice conversation. It has. Emily, Sandra's voice had lost its pleasant register. What was underneath it was harder to name. Not malice, not exactly, but something stressed and uncertain and slightly resentful of the uncertainty. I'm trying to tell you that you should think carefully about how you present what happened tonight. Emily finished the line she was typing. She saved the entry. Then she turned to look at Sandra with the direct, undramatic attention that she'd been giving people all evening. I performed 2 emergency procedures that kept 2 patients alive while an active mass casualty event was ongoing, she said. I identified a Legionella outbreak in a military unit that might have otherwise gone undetected for days. I reorganized the ER response to a combined trauma chemical event that our standard protocol wasn't designed to handle. I'm going to tell Rowan exactly that, in exactly that order, with the documentation to support every piece of it. She paused. Is there something in that account you think I should present differently? Sandra said nothing. Because if there is, Emily continued, I'm open to hearing it. There was a long pause. No, Sandra said, and she walked away. Dr. Elliot Rowan arrived at 10:43. He was a lean man in his mid-60s who had come in through the administrative entrance in a coat that was still wet from the parking lot, which meant he'd driven himself rather than waiting for someone to bring a car around, which told Emily something about him. He moved through the ER with the practiced efficiency of someone who had spent decades in clinical environments before moving into administration and hadn't entirely left the clinical instinct behind. He went to Lowe first, which was correct. Lowe was the attending, the operational authority in the room. Emily watched from the nurse's station as they spoke. She couldn't hear the words over the ambient noise, but she could read the posture. Lowe was talking. Rowan was listening with the particular quality of listening that meant he was assembling rather than reacting. Then Rowan looked at Mercer. They spoke for 4 minutes. Mercer showed him something on his phone. A document, possibly a record. Rowan's expression didn't change much, but something in his posture shifted in a way that was almost imperceptible. He looked at the phone for longer than a casual glance required. Then he walked to the nurse's station. Ms. Hart, he said. Dr. Rowan? He sat down in the chair across from her, which was unusual. Administrators typically stood when they came to the floor. It was a posture thing, a status management thing, conscious or not. Sitting across from her at the nurse's station meant he was meeting her at the level of the work, and she filed that without making anything of it. I've gotten several accounts of tonight already, he said. I want yours. She gave it to him. Clean, sequential, clinical. She went through the evening in the order it happened, starting with the construction worker in the morning, moving through the mass casualty event, the airway on Petra Voss, the restructured triage, Captain Webb's arrival, Commander Rask's pericardiocentesis, and Corporal Ward's Legionella workup. She spoke for 9 minutes without stopping. She didn't editorialize. She didn't frame. Rowan listened without interrupting. He had a small notepad on the desk that he occasionally wrote something on, but not much. Most of it he held in his head. When she finished, he was quiet for a moment. The procedures you performed, he said. The cricothyrotomy and the pericardiocentesis. You understand that both of those fall outside the registered nurse scope of practice in this state? Yes. And you performed them anyway. In the cricothyrotomy, the patient was going to die in under 60 seconds, and Dr. Lowe had already attempted and failed intubation. In the pericardiocentesis, Commander Rask had cardiac tamponade from a penetrating chest injury, and there was no physician in this facility with the training to perform the procedure safely under those conditions and that time constraint. She met his eyes. I'm not arguing scope of practice is irrelevant. I'm saying that scope of practice exists to protect patients, and in both those cases, following scope would have killed the patient that it was designed to protect. Rowan looked at her. That's a significant statement, he said. It's an accurate one. Another pause. Captain Webb, Rowan said, has submitted a report to his commanding officer and copied the Naval Special Warfare Medical Command. He describes you as, and I'm reading here, he glanced at his notepad, the most proficient emergency medical practitioner I have encountered in a non-combat theater. He looked up. That's a specific phrasing. Emily said nothing. I asked Mercer about your record, Rowan said. He told me it's partially classified, which was not the answer I expected. My prior service involved specialized medical operations, she said. The specific details aren't information I'm authorized to share without a formal records request. Rowan nodded slowly. He was connecting things. She could see it, the way a picture assembled from fragments was assembling now behind his eyes. Sandra Polk submitted a formal complaint about your conduct 2 weeks ago, he said. I didn't act on it immediately because it described interpersonal friction that I see between new and senior staff with some regularity, and I was monitoring. I know about the complaint, Emily said. You know about... He stopped. How? I heard Sandra tell Dr. Lowe to document me. I assumed a formal complaint would follow. She kept her voice neutral. It didn't change what I needed to do. Rowan sat back slightly. The ER around them was doing its work. Monitors and voices and the movement of people between bays. Ward's infusion was running. Petra Voss in Bay 6 had been transferred to the ICU an hour ago, stable. The last of the mass casualty patients was being managed by Lowe with a thoroughness that Emily had been monitoring from a distance. The room was not calm. It had never been calm tonight, but it had found its rhythm. I'm going to have several conversations tomorrow, Rowan said, with the medical board, with the state licensing office, with Captain Webb and with Mercer. He looked at her. And with Dr. Lowe and Sandra Polk. Emily nodded. Whatever comes out of those conversations, she said, I'll cooperate fully. I'm aware of that. He stood up. He looked at her for a moment with an expression that was more complicated than she'd expected from him. Go finish your shift, Ms. Hart. We'll talk in the morning. He walked toward the administrative corridor. Emily turned back to her workstation. She pulled up Ward's chart. His last pressure read 97/62. Better. His temperature was 39 even. Still elevated, but no longer climbing. The levofloxacin was doing its work. She made a note in the chart and moved on to the next patient. At 11:58, the ER was as quiet as it had been all night. Quiet for this particular night, which meant 3 patients in monitored bays, 1 being prepped for overnight admission, Alicia finishing end-of-shift documentation at the desk, Troy doing equipment checks in the back corridor. The blizzard outside had neither worsened nor improved. It had simply settled into permanence, the kind of snow that stopped being an event and became a condition. Emily was in the break room. She was sitting at the small table with both hands around a cup of coffee that had gone from hot to warm to something between warm and cold while she sat there. She wasn't drinking it. She was doing the particular kind of nothing that she'd gotten good at, the deliberate absence of thought, the rest that was possible when you stopped performing and simply existed in a room. Her dog tags were in her right hand. She wasn't sure when she'd taken them out from under her scrubs. At some point in the last hour, she had unclasped the chain and pulled them out, and now she was holding them, the metal warm from her body, the edges worn smooth in the specific ways they got worn smooth when they lived against skin for a long time. She wasn't looking at them. She was just holding them. The break room door opened. Low. He stood in the doorway for a moment, looking at her, and she looked back at him, and neither of them said anything for a few seconds that weren't uncomfortable exactly, but had a weight. Ward's stable, he said. I know. I checked 20 minutes ago. He came in and poured himself coffee from the same pot and sat down at the other end of the table. He didn't try to sit close. He sat at a distance that felt like he was respecting a border he could sense, even if he couldn't see it. He looked at the dog tags in her hand. She didn't put them away. Navy? He said. Fleet Marine Force, she said. Corpsman. Special operations attached. He processed that. How long? 8 years of service. 3 deployments. He wrapped his hands around his mug. He was a man who asked direct questions, and she understood that about him, and she waited for the one that was coming. Why here? He said. Why this? Why did you... He stopped, reformulated. You could have gone anywhere. With that background, you could have walked into a trauma center anywhere in the country. I know. So why Harwick? Why Duluth? She looked at the table for a moment. I needed to stop, she said. After the last deployment, I needed to be somewhere quiet and do something that didn't... She paused. Found the right word, or close enough. Didn't cost as much. He was quiet. How's that working out? He said. And there was something in it. Not sarcasm, more like the dry acknowledgement of a man who had enough self-awareness to recognize irony when it was sitting in front of him. She looked at him. Ask me in the morning, she said. He almost smiled. Not quite. He drank his coffee. She held her dog tags. They sat there in the break room at midnight while the blizzard ran its hand across the building, and they didn't talk. And it was fine. Well, she was back on the floor at 12:19 when the radio went. Not Alicia's desk radio, the emergency band, the one patched into the county EMS frequency that ran as background in the corner, and that most of the night staff had learned to parse while doing other things, picking out the relevant signals from the static and the routine traffic. The relevant signal this time was not subtle. Unit advising all area hospitals, we have a secondary incident on 61. Bridge structure at mile marker 28. Possible compromised integrity following the pileup chain. We have some standby, so we have a vehicle through the guardrail, partial submersion in tributary. Multiple occupants. EMS and fire en route, timeline unknown given road conditions. Requesting hospital standby for potential cold water trauma, multiple victims, unknown count. Alicia looked up. Emily was already at the desk. Get low, she said. Cold water trauma was a specific category. The tributary off Highway 61 at mile 28, she knew the geography, she'd driven that road, was the Kessler Creek drainage, which in February was running near freezing under a partial ice shelf. Vehicle submersion in those temperatures meant hypothermia onset within minutes, which stacked on top of whatever traumatic injuries the accident itself had produced. Submersion cases were also unpredictable in a specific way. People who appeared dead on extraction sometimes weren't, because the mammalian diving reflex could preserve core function in cold water past the point where warm water submersion would have been fatal. You don't declare cold until they're warm and dead. That was the rule, and she had followed it before, in worse conditions than these. Lowe appeared from the back corridor at a jog. How many? He said. Unknown, partial submersion, multiple occupants, estimated minimum 3. Timeline? EMS is trying to get there through the conditions on 61. Could be 20 minutes, could be 40. She was already thinking ahead. Warming protocols, the supplies they'd need, the bays they'd have to reconfigure. We need to pull the warming blankets from storage, get the warmed IV fluid set up, and if we have anyone still on shift from respiratory, they need to stay. Cold water extractions can present with pulmonary edema, even if they look okay initially. Lowe was nodding. He was good in the acute phases. She'd watched him all night, and she knew where his capabilities were, and they were real. I'll call respiratory, he said, and moved. Emily started pulling the warming protocol checklist. She was halfway through it when Alicia said from the desk, with a careful voice that she used when something she was about to say didn't fit the category of normal things. Emily. She looked up. Alicia was holding the radio. She had a look on her face. The vehicle, Alicia said. EMS is describing it. They're saying it's a military transport. Emily went still. Which convoy? She said. They don't know. It came off the bridge. They're saying it wasn't in the original pileup. It's a different vehicle. It might have been diverted around the original incident and taken the bridge route instead. Alicia paused. They're saying there's a woman in the vehicle, civilian, and she's trapped. Emily looked at the radio. She looked at the window, at the blizzard, at the parking lot lights catching the snow. She thought about the convoy's route, about the 3 vehicles Mercer had mentioned, about the 2 that had come to the hospital and the 3rd that had been accounted for, and the routing that military convoys took through civilian road networks when primary routes were blocked. Get me Mercer, she said. He left 20 minutes ago. Get me a number. Alicia was already scrolling. Emily looked at the emergency band radio and thought about a vehicle in Kessler Creek in February at a water temperature of 3 degrees Celsius with a woman trapped inside it, and thought about what 30 minutes in that water would do to a person. Lowe came back from the corridor. Respiratory is staying, he said. We've got 2 warming bays set. He saw her face. What? The vehicle in the creek, she said. I think there's more to it. I think... The radio cut through. All units. Secondary advisory from the Kessler Creek extraction. Rescue teams on scene report. They have partial contact with the trapped occupant. Civilian female, conscious, ID confirmed. A pause, the specific static-filled pause of a channel switching. Confirmed as Dr. Nora Webb, traveling as a civilian escort with the military convoy. Repeat, Dr. Nora Webb. She is asking, Stand by. The channel filled with background noise, wind, the sound of water, the sound of men shouting at each other over both. Then, she is asking for someone named Hart. She says Hart will know what to do with her. The ER went completely silent. Every person on that floor stopped moving. Emily stood at the desk with the checklist in her hand and the radio in front of her and the silence of 14 people waiting, and she understood, in that moment, with a clarity that was almost physical, that this was not over, that the night had not reached its end, that the thing she had been telling herself was almost finished was in fact inside something much larger, something that had a shape she hadn't seen yet. She put down the checklist. She picked up her trauma kit. She looked at Lo. "I need to go to the creek," she said. Lo stared at her. "The road is—" "I know what the road is." She was already moving toward the ambulance bay. "Get the warming bays ready. I'll have her back here inside 45 minutes. Emily." His voice had something new in it. Not authority, not objection, something closer to concern. "You don't have to—" "She asked for me," Emily said, "by name." She hit the ambulance bay door. The cold came at her like a physical thing, and somewhere in the dark and the snow and the sound of ice-cold water moving under a broken bridge, a woman who knew her name was waiting. The ambulance bay door hit the wall behind her, and the cold came in like something that had been waiting. It was a different cold from the cold of early evening, deeper, wetter, the kind that got into the joints and the sinuses simultaneously and made thinking feel like it required more effort than it should. The blizzard had not softened. If anything, it had organized itself, found a direction and committed to it, the wind coming off the lake at a consistent angle that pressed against everything vertical and made the ambulance bay lights swing on their housings. Emily moved to the EMS staging vehicle, a county rig that had been parked at the far end of the bay since the first wave and hadn't left because the road conditions had deteriorated past the point where leaving made operational sense. The driver, a heavy-set man named Carl, who had been sitting on the running board drinking bad coffee for the last hour, stood up when he saw her coming with her kit. "Kessler Creek," she said. "Can you get there?" He looked at the road. He looked at her. He looked at the road again. "Probably," he said, which she understood to mean yes with a specific caveat about the word probably. "Let's go," she said. She climbed in. He climbed in. He had the engine running before she had the door closed. The radio on the dashboard was still carrying the EMS frequency, and as Carl pulled the rig out of the bay and onto the access road, she listened to it with the half-attention of someone who was simultaneously running a parallel calculation about what she was going to find and what she was going to need. The updates from the creek were fragmentary. Rescue teams on site, partial ice breakage complicating access, the vehicle described as a military transport van sitting at a 40-degree angle in the creek bed with its rear end still on the bank, and the front cab submerged to the windshield level. Windshield level. That was the thing she held on to. If the cab was submerged to the windshield, it meant the occupant, Dr. Nora Webb, whoever that was, had an air pocket. Potentially. If the vehicle's orientation hadn't shifted since the initial report, if the ice hadn't closed in around it, if the woman inside hadn't lost consciousness and slid down into the water. 3 conditionals stacked on each other, each one requiring the previous to be true, and all 3 needing to still be true when Emily got there. Carl drove the way Emily had hoped he would, not recklessly, because reckless on an iced highway at midnight was how you ended up as a secondary incident, but with the specific aggressive competence of someone who had driven emergency vehicles in Minnesota winters long enough to understand what the road would and wouldn't tolerate. He read the surface with the front wheels, corrected small slides before they became large ones, and said nothing, which she appreciated. Highway 61 was a graveyard. She hadn't seen it from the road during the initial event. She'd been inside the hospital through all of it, and now seeing it from the cab of the rig was something she hadn't entirely prepared for. The pileup itself was 3 miles north of the hospital and had been partially cleared by the time they reached it, but partially wasn't entirely, and the road surface through the cleared section was a record of impact. Fluid stains, scattered debris, the gouged asphalt where vehicles had left the road. Emergency lights from the remaining police units cast everything in alternating red and blue that made the snow look like it was bleeding. She made herself look at it clinically. Evidence of force. Evidence of speed and surface failure. Evidence of the specific way that a chain of events began with one bad decision on a frozen road and expanded outward until it touched everything in its radius. Mile marker 28 was 4 miles north of the pileup site. The bridge was a 2-lane span over the Kessler Creek drainage, maybe 60 feet across, with guardrails that had been adequate for normal conditions and had not been adequate for whatever had come off the main road and onto this bypass route at speed. On the left side, about 30 feet from the bridge's north end, the guardrail had given way, a clean break with the rail ends bent outward and down in the specific geometry of a heavy vehicle going through it rather than bouncing off it. Below, the creek. Carl pulled the rig off-road onto the shoulder above the break point, and Emily was out before he fully stopped, moving to the edge, looking down. The vehicle was a military transport, a dark green van, the kind that carried personnel rather than equipment, sitting at roughly the angle the radio had described with its front end in the creek and its rear wheels still contacting the bank. The creek wasn't deep, maybe 4 feet at the center channel, but 4 feet was enough when the temperature was what it was, and the vehicle's front cab was taking on water through whatever gaps the impact had opened. 3 rescue personnel were already on the bank below, 2 of them in cold water gear, attempting to establish a line to the vehicle. A 4th was at the top of the bank talking into a radio. Emily went down the bank. It wasn't a gentle slope. It was a 15-foot drop with frozen vegetation and snow-covered rock, and she went down it the way she'd gone down worse things, with her hands and her feet and the specific controlled urgency of someone who understood that falling was a delay she couldn't afford. She landed at the bottom with both feet and moved to the rescue team. "I'm the medical," she said. "What's her status?" The lead rescuer, a woman in her 40s in a dry suit, ice still in her hair from a previous submersion attempt, looked at her with the quick assessment of someone evaluating a new asset. "Conscious when we last made voice contact 4 minutes ago. She's wedged against the passenger door. Driver's side is fully submerged. She's got partial water contact at her lower body. She says she can't feel her legs." "Can't feel or can't move?" She said can't feel. "We don't know if it's the cold or injury." Emily looked at the vehicle. The front cab was tilted left and down, which meant the driver's side was lower, which meant the water was deeper on that side, which meant the woman inside had probably been bracing herself to the right, against the passenger door, for however long she'd been in there. How long had she been in there? "Time of the accident," Emily said. "Dispatch got the call 41 minutes ago. Actual accident, unknown, probably 5 to 10 minutes before the call. 45 to 50 minutes in contact with 3-degree water, lower body." Emily ran it. Hypothermia onset was faster in water than air. Immersion accelerated heat loss by a factor of 25 over air exposure at the same temperature. 50 minutes with lower body immersion at 3 degrees meant core temperature was dropping, mean the woman's cognition and muscular control were degrading, and meant that if she lost the grip she'd been maintaining on the passenger door, she was going to slide into the deeper water on the driver's side. "I need to get to the vehicle," Emily said. The lead rescuer looked at her. At her kit. At her clothing, which was her hospital scrubs under her jacket. Not cold water gear, not a dry suit, not anything rated for creek submersion in February. "We have a suit in the—" "No time to suit up," Emily said. "What's the quickest line to the passenger door?" "You can't go in without—" "I'm not going in. I'm going across the roof if the vehicle is stable enough." She looked at the vehicle again. The rear wheels were on the bank, the chassis was resting against the creek bed, and the position had been stable for at least 40 minutes, or it would have shifted further by now. "Is it moving?" The rescuer looked at the vehicle, at her partner, back at Emily. "Not in the last 15 minutes, she said. "Then I can use the roof. Give me a belay line." Getting across the vehicle's roof was the ugliest 40 seconds of the night. The metal was ice-sheeted, not just cold, not just wet, but coated in the specific glaze of water that had frozen on contact and then been refreshed by spray from the creek and frozen again. Her boots found traction on the roof seam and nowhere else, and she moved by feel more than sight, the belay line from the rescue team playing out behind her as she went, her hands finding the cargo rack bolts and the antenna mount and one protruding hinge that had no business being as useful as it was. She got to the passenger side. She got flat against the roof and looked down through the passenger window. Dr. Nora Webb was real. That was the first thing Emily registered. the specific vividness of a person in crisis, more real than the ambient scene around them, the way a face under emergency circumstances had a detail and presence that the surrounding situation somehow lacked. She was maybe 50, dark hair plastered to her face, her right arm hooked through the grab handle above the door, with the white-knuckled grip of someone who had been holding that position for going on an hour. Her lower body was in dark water. Her face was pale in the way that cold made people pale. Not the gray of shock, but the specific bloodless white of a body redirecting circulation to its core. But her eyes were open and tracking, and when Emily's face appeared in the window above her, she said something. Emily couldn't hear through the glass and the wind. She pointed to her ear and shook her head. Webb lifted her chin, tried again, louder. Emily could lip read well enough. "Your heart." She held up one hand. "Yes." Webb's expression did something complicated. Not relief exactly. More like the specific exhale of someone who has been managing on their own for a long time and has just been told that the management period is almost over. Emily looked at the window. Standard tempered glass, the passenger window, which would not break cleanly. It would spider and hold, which was fine for her purposes. She pulled the spring-loaded window punch from her kit, pressed it against the lower corner, and triggered it. The glass spider-webbed. She pushed it inward in a controlled collapse, not into the vehicle, and the wind and cold came through the opening immediately. "Dr. Webb," she said. "Emily Hart, I'm going to get you out. Tell me where it hurts." Webb's voice was slower than it should have been. The cold was in it. "Left leg," she said. I think the dashboard came down. I can't see it. I can feel something, but it comes and goes." Which meant intermittent sensation, which was better than no sensation, which meant the problem was probably positional compression or early hypothermic nerve disruption rather than a cord injury. Probably. Emily filed the probability and moved past it. "Can you move your right leg?" Webb tried. Emily watched her face. "Yes. A little." "Okay. I'm going to reach in and I need you to not let go of that handle until I tell you. Do you understand?" "Yes." Emily reached through the window opening, got her hands under Webb's right arm, checked the grip. The belay line was still attached to her. She turned her head and made the hand signal to the rescue team below. "Prepare to take load," and felt the line go taut. "On 3, Emily said. 1, 2, 3. The extraction was not clean. Webb's left leg was in fact caught, not by the dashboard as she'd described, but by the seat track mechanism, which had buckled inward when the cab deformed and had closed around her ankle like a jaw. Emily felt the resistance the moment they started pulling and stopped immediately. Stopping was the correct decision. Stopping was always the correct decision when you felt unexpected resistance during an extraction, because what the resistance meant was always more important than the time you lost stopping. "Your left ankle is caught," Emily said. "I'm going to need to work it free. Hold on to the handle." Webb nodded. Her jaw was tight. She was controlling something. Pain, cold, the specific fear of a person who understood enough about their situation to know it was bad. Emily reached deeper into the vehicle. The water came up over her elbow, into her sleeve, and it was so cold that it felt like a burn. The specific paradox of extreme cold registering as heat before the nerves recalibrated. She got her hand to the seat track, felt the buckled metal, felt Webb's ankle within it, and began working. It took 6 minutes. She knew because she counted. 6 minutes with her arm in 3-degree water working by feel with the wind on her back and the vehicle shifting once, slightly, at minute 4, a shift that made the rescue team below call out and made Emily press her body harder against the roof and keep working. The ankle came free. Webb made a sound she clearly hadn't planned on making. Emily pulled her hand back and the cold followed it up her arm like something with intent. "Okay," Emily said. "Now we go. Don't let go until I tell you." They went. Getting Webb out of the vehicle and across the roof and down to the creek bank was a team effort in the literal sense. Emily managed the upper body. The rescue team managed the line. Carl appeared at some point on the bank with a thermal blanket that he must have pulled from the rig, and nobody spoke except in the specific clipped language of people doing a technical task that required coordination and not conversation. Webb's feet hit the bank. Emily landed beside her, both of them down on the frozen ground, and for a moment neither of them moved. Emily was aware of her right arm, which had stopped hurting in the way that body parts stopped hurting when the cold got deep enough, and she filed that as something to address after the patient, always after the patient. "Stay with me," she said to Webb. "I'm here," Webb said. Her voice was clearer than it had been in the vehicle. Cold air versus cold water. Cold air was survivable in ways that cold water wasn't. "I'm here." Emily did the assessment with her left hand, the one that still had sensation. Pulse, present, bradycardic, maybe 52. Skin, cold but not the waxy texture of severe hypothermia. The leg. Webb's left ankle had a deformity that was visible even through the wet clothing, a lateral displacement that meant fracture. But a fracture was a fracture, and fractures didn't kill people on their own. "Core temp's the priority," Emily said to the rescue lead. "Get the blanket on her. Get her to the rig. I need warmed fluids in her before we drive." She looked at Webb. Webb was looking back at her with an expression that was more focused than it had any right to be given the circumstances. "Captain Webb," the woman said. Emily looked at her. "Marcus Webb, the officer who came to your hospital tonight." Webb paused. Her breathing was still effortful. "He's my brother." Emily held that for a moment. "He said you'd know what to do," Webb said. "When they reached me on the radio, I didn't know your name, but he'd described you. He said to ask for the nurse, and she'll handle it." A pause. "He didn't say nurse like it was a small thing." Emily didn't say anything. She put her hand on Webb's shoulder, not as a gesture, as a pressure assessment, checking the muscle response. "Let's get you warm," she said. "We'll talk when you're not hypothermic." The drive back to Harwick Regional took 22 minutes and felt like more. Emily had gotten the warmed saline running into Webb's right arm within 4 minutes of loading her into the rig, had packed her in every thermal layer Carl's rig carried, and had spent the drive doing the ongoing assessment that hypothermia cases required. Temperature trending, cardiac monitoring via the portable lead she'd attached, the specific watch for the cardiac arrhythmias that cold-induced myocardial irritability could produce. Webb's core temp on the field thermometer read 34.1, which was moderate hypothermia, which was serious and manageable in that specific order. She also wrapped her own right arm in the spare thermal layer and held it against her body, and did not think about it. Webb, in the warmth of the rig, was becoming more coherent in the specific way that hypothermia patients became more coherent as their core temperature improved. Not all at once, but in steps, like a signal clearing. "I was at the hospital," she said, at some point around mile marker 31, before the convoy. "I was with the team as a civilian medical consultant. I was supposed to go back with the third vehicle." "The one that took the bridge route," Emily said. "Road was blocked. The driver rerouted." Webb paused. "He's okay." "The driver. He got out before the vehicle went over." Emily nodded. "What kind of consultant?" she said. "Not prying." The answer was relevant to the patient's recent history and stress load, which was relevant to her clinical status. "Infectious disease," Webb said. "I was the one who identified the Legionella risk at the mill site. That's why the convoy was pulling back. I'd recommended immediate withdrawal 3 days ago." She paused. "The recommendation got delayed at the command level. Corporal Ward was already symptomatic by the time they moved." Emily looked at her. "You tried to get them out earlier," she said. "I put it in writing." Webb's jaw tightened. Not from cold. "It went up the chain. It came back with a delay authorization." She paused. "Ward is he—" "Stable," Emily said. "Legionella confirmed. He's on levofloxacin and his pressure is responding." Webb closed her eyes, opened them. "Good," she said. "That's good." They rode in silence for a moment. Then Webb said without preamble, "My brother told me what happened at your hospital tonight. Not everything. He gave me the overview before we lost contact. He said a nurse managed a mass casualty event, performed emergency procedures, and organized a military medical extraction, and that the hospital had been treating her like she was barely competent." She looked at Emily. "Is that accurate?" Emily considered what to say. "It's a version," she said. "He also said she was one of the best corpsmen he'd encountered in 15 years of operational medicine." Webb's voice was steadier now. "And he doesn't say things like that. He says adequate and solid and occasionally exceptional, and I have heard him say exceptional twice in my adult life." Emily looked at the road through the windshield. "He was generous," she said. "He was accurate," Webb said. "There's a difference, though." Harwick Regional at 1:27 in the morning had a quality she hadn't seen in it before. Not quieter. There were still people moving, still monitors, still the ambient machinery of a hospital that didn't stop. But something in the quality of the activity had changed. She noticed it when Carl pulled the rig into the bay and Lowe came out to help transfer Webb, and the way he moved, toward the patient, purposeful, without the sideways look he usually gave Emily to check whether she was doing something he should weigh in on. He just helped. They got Webb inside, into the warming bay, onto the monitor. Emily gave her hand off while she was still in her coat. Temperature trending, cardiac rhythm, the ankle fracture, the saline running, the timeline. Lowe listened, took the chart, and moved to the patient. Emily stepped back. She stood in the corridor outside the warming bay and became aware, in sequence, of several things. Her right arm, which had transitioned from the absence of feeling into a specific deep ache that was actually a reassuring sign. Pain meant sensation returning. Sensation returning meant circulation. Her back, which had filed its third complaint of the evening and was now making it impossible to ignore. Her feet, which were wet from the creek bank and cold in the way that feet got cold when they'd been cold for a long time and the body was busy with other problems. She was standing there doing inventory when she heard the voices, coming from the direction of the administrative corridor. Not arguing. It was too controlled for arguing, but tense in the way that controlled conversations got tense when the people involved understood that the wrong word could end careers. She walked toward it without deciding to. Rowan was in the corridor outside his office. Mercer was beside him, and in front of them, standing with the posture of a woman who had expected to be in a different position in this conversation, was Sandra Polk. Sandra had a folder. She was holding it in a way that had looked probably like confidence when she'd picked it up, and now looked like something she wasn't sure what to do with. Submitted the complaint formally, Sandra was saying, and the procedures she performed tonight are a clear scope violation regardless of the outcome. The outcome, Mercer said, with a flatness that cut the sentence in half, is that two people are alive who wouldn't be. That's not how liability. Dr. Webb, Mercer said, is an employee of the Department of Defense. Commander Rask is active-duty naval personnel. The procedures performed on both of them tonight occurred in the context of a declared mass casualty event during which the senior attending physician had either attempted and failed the procedure in question or was not present. He looked at Sandra with the expression of a man who wrote reports for a living and was currently writing one in his head. The liability question is not what you think it is. Sandra looked at Rowan. Rowan looked at the folder in Sandra's hand. The complaint you filed 2 weeks ago, he said. Walk me through the specific incidents you documented. Sandra straightened. She opened the folder. She began reading. The accumulated record of 11 weeks of friction, phrased with the careful professional language of formal complaint documentation. The failure to follow established protocol. The pattern of overstepping. The disruption to team culture. Emily stood at the end of the corridor and listened. She had not announced herself. She was aware that she should, that standing in a corridor listening to a conversation about herself was not the posture she wanted to be in when this conversation happened. But she was also very tired and her arm ached, and she had been in a creek 40 minutes ago, and she stood where she stood and listened. November 14th, Sandra was reading. Ms. Hart intervened in a triage assessment being conducted by senior nurse Alicia Rand, overriding her priority classification for a patient who had an MI that got caught early, Rowan said. Sandra looked up. The complaint is about the intervention, not the outcome. I understand what the complaint is about. Rowan's voice was quiet, in the way that Rowan's voice was always quiet, and it landed differently than volume would have. I'm asking about the pattern. Because from where I stand, the pattern I'm seeing is a staff member with significantly more clinical experience than her peers making correct calls that her peers and supervisors were resistant to, and a formal complaint that documented that resistance as the problem rather than as the symptom of something else. Sandra was silent. Tell me something, Rowan said. In 11 weeks, did Emily Hart make a clinical error? A pause. Not that I documented, Sandra said. Not that you documented. Rowan nodded slowly. And in 11 weeks, how many times did the assessments she raised turn out to be correct? The pause was longer this time. I'm not here to evaluate her clinical record. Sandra. His voice didn't rise. How many times? Sandra looked at the folder. She closed it. She didn't answer, which was its own answer. Emily, at the end of the corridor, watched the folder close. She had carried 11 weeks of careful neutrality, 11 weeks of absorbing the daily diminishment of being handed the wrong tasks and assigned the wrong shifts, and talked past as though her presence was coincidental rather than deliberate. She had carried it the way she'd learned to carry things that couldn't be put down yet, not by ignoring them, but by placing them somewhere in herself that wouldn't interfere with the work. The folder closed, and something in her settled. Not victory. She didn't feel that. She felt tired and cold and something quieter than vindicated. The specific weight reduction of a thing that had been held too long finally being set down. Rowan looked up. He saw her. He didn't seem surprised. "Ms. Hart," he said. "How's Dr. Webb?" "Warming well," Emily said. "Core temp was 34.1 on extraction. She's got a lateral malleolus fracture. She should be stable." He nodded. He looked at her arm, which she was still holding slightly against her body. "Is that arm okay?" "It will be," she said. "I need to warm it properly." "Go do that," he said. "I'd like to see you in my office at 8, if you're willing." "I'll be here," she said. She turned to walk back to the bay. Behind her, she heard Rowan say, to Sandra, in the tone that preceded administrative conversations that nobody looked forward to, "Come inside." And then the office door closed. She was in the break room again. Different coffee, this time hot, cradling the cup in both hands with her right arm submerged to the elbow in the warm water basin that Troy had set up with the specific, thoughtful efficiency of someone who had been watching her all night and had pre-solved the problem. Troy was leaning against the counter. He was 24, maybe 25, and he had the look of someone who had learned more in the last 6 hours than in the previous 6 months and was still processing the intake. "Can I ask you something?" he said. "Sure," she said. "Why did you stay?" "At Harwick. After the first week, I mean. It was obvious they were—" He stopped. "It seemed like you could have gone anywhere." She looked at the warm water around her arm. Feeling was coming back in the specific tingling way that it came back, which was uncomfortable and correct. "I needed the quiet," she said, "even when it wasn't quiet." He thought about that. "Does it work?" he said. "The quiet thing?" She looked at him. He had honest eyes, the kind that asked questions because they actually wanted the answer. "Not the way I thought," she said, "but some other way." He nodded, as though that made sense, which possibly it did. She held her coffee. Outside the break room window, the blizzard was still running. It had been running all night, consistent and indifferent, and she had stopped registering it as a condition and started registering it simply as the sound the world was making right now. Her phone, on the table, lit up. Unknown number. Area code she didn't immediately recognize. She picked it up. "Hart," she said. The voice on the other end was Captain Marcus Webb's, slightly compressed by a satellite delay that put him at significant distance. "Dr. Rask is in surgery," he said. "They opened him up 40 minutes ago. The surgical team says the tamponade drain you performed bought them a viable window. They're describing it as the difference between a repairable injury and an unsurvivable one." She absorbed that. "Your sister is here," she said. "She's stable." A silence on the line that had something in it. "I know," he said. "They told me when we landed." Another pause. "I owe you several conversations I don't have the words for right now." "You don't owe me anything," she said. "That's not your call to make," he said. And there was something in his voice that wasn't sentiment. It was more particular than that, more operational, like a man who kept accounts and intended to balance this one. "I'm going to make some calls in the morning, Hart, before your 8 o'clock with Rowan." She looked at her coffee. "You don't need to do that," she said. "Again," he said, "not your call." The line cut. She set the phone on the table. She picked up her coffee. She held it. Troy had gone back to the floor a few minutes ago, and the break room was empty. Outside, the blizzard pressed against the glass. Inside, the hospital ran. Monitors and footsteps and the quiet machinery of a place that kept going, regardless of what happened within it. She was almost at the end of the worst and best shift of her time at Harwick Regional, and she knew that the 8 o'clock meeting with Rowan was going to be a different conversation than any she'd had in this building, and she knew that Webb's calls in the morning were going to land somewhere specific, and she had a reasonable estimate of what both of those things meant for the days ahead. What she didn't know, what she couldn't have anticipated, was that at 7:48 in the morning, 12 minutes before she was due in Rowan's office, Sandra Polk was going to walk into the hospital administrator's suite with a second document that she had prepared overnight, and that this document was not another complaint about Emily Hart, but something structurally different, something that had been assembled with the help of a hospital attorney who had been called at 2 in the morning, and that what it contained was going to force Rowan into a choice that nobody in the building had anticipated, and that the person who would walk through Rowan's office door at 8 o'clock precisely and see the document on the desk and understand immediately what it was Emily Hart. She walked into Rowan's office at 8 o'clock with her right arm still slightly stiff and her scrubs changed to the clean set she kept in her locker and the specific tiredness of a person who had not slept but had passed through the zone where sleep was possible and come out the other side into something that felt like clarity. The document was on the desk. She saw it before she saw anything else, before she registered Rowan behind the desk or Mercer in the chair to the left, or the fact that there were two other people she didn't recognize sitting against the far wall with the flat, precise posture of attorneys. The document was a single stapled packet, maybe 12 pages, and it was sitting in the center of the desk with the careful placement of something that someone had wanted to be seen. She sat down across from Rowan. She looked at the document. "Tell me what it is," she said. Rowan looked at her. He had the look of a man who had been up most of the night and had arrived at a particular decision somewhere around 4 in the morning and had spent the hours since building the steadiness to carry it through. Sandra Polk, in consultation with the hospital's legal counsel, has filed a preemptive liability instrument, he said. It's essentially a formal assertion that the procedures you performed last night constituted unauthorized medical practice, and that the hospital's failure to enforce scope of practice guidelines created an institutional liability that she is, and her attorney is, prepared to escalate to the state licensing board and potentially to civil action. Emily looked at the document, 12 pages, assembled between 2 and 7 in the morning by a woman who had understood at some point during the night that the accounting was going to happen and had decided to file her version of it first. She's arguing, Rowan continued, that by performing a cricothyrotomy and a pericardiocentesis without physician authorization, you expose the hospital to significant malpractice risk, and that her prior complaint about your conduct was evidence of a pattern that administration failed to act on. He paused. The argument is that she was right, and we were negligent for not listening. Emily said nothing. She was looking at the document, but she was thinking about Petra Voss, who had been breathing on her own in the ICU since midnight. She was thinking about Commander Rask, who was in surgery at a military facility because a pericardiocentesis in a darkened bay had bought him the time to get there. She was thinking about Corporal Ward, whose fever had broken at 3:47 in the morning, according to the update Troy had texted her at 4, a text she had read sitting on the break room floor with her back against the wall. She thought about all of those people, and then she looked at the 12-page document, and she understood that the document was afraid of them. "What does legal say?" she said. "Our legal team has been working since 5, Rowan said. Their assessment is that Sandra's instrument has structural problems. The mass-casualty declaration, which was formally logged at 1809, creates a specific legal context for emergency intervention that our filing does not adequately account for. Under Minnesota statute, a declared mass casualty event alters the scope parameters for clinical intervention in ways that her attorney either didn't research thoroughly or chose to present selectively." "So it doesn't hold, Emily said. "It doesn't hold as written, but it creates a record. It creates a narrative." Rowan looked at her directly. "And narratives have weight even when the underlying document is legally insufficient." Emily understood what he was telling her. The document was a weapon that wouldn't win a war but could do damage in the exchange, could follow her into the next position, the next licensing review, the next professional conversation where someone pulled her record and saw the flag and made an assumption without reading the context. That was the calculation Sandra had made at 2 in the morning. "There's also this," Mercer said. He put a tablet on the desk. She looked at it. It was a document from the Naval Special Warfare Medical Command, time-stamped at 6:41 that morning, and it bore Captain Marcus Webb's name as the originating officer. She read it in 30 seconds. It was a formal commendation, specific and detailed, describing her actions with Commander Rask in clinical terms that left no room for interpretation. The assessment, the decision, the execution, and the outcome, documented in the language of military medical evaluation by someone who had been in the room and had the credentials to judge what he'd seen. Below Webb's commendation was a second document, Dr. Nora Webb's name, a statement from her regarding the Legionella identification in Corporal Ward's case, describing Emily's assessment in the context of her own infectious disease expertise with a specificity that constituted professional endorsement. Below that, a third. The attending surgeon at the military facility where Rask had been taken, describing the condition of the pericardial repair on arrival and the surgical team's assessment that the intervention had been performed with a precision that, and she read the exact phrase, would have been exceptional under any conditions and was remarkable under the described conditions. Mercer said nothing while she read. He let the documents be what they were. She put the tablet down. "These were Webb's calls in the morning," she said. "He made 4, Mercer said. "Those are 3 of them." "What was the 4th? Mercer looked at Rowan. Rowan looked at Emily. "The 4th, Rowan said, "was to me, at 7:15. It was a brief call. He told me that if this hospital allowed Sandra Polk's filing to define last night's events, he would be submitting a full operational report to the Naval Medical Center's Institutional Review Board describing the conditions under which their personnel received care at this facility, including the systemic undermining of the clinician who provided that care." He paused. He was very calm about it. That made it more rather than less serious. Emily sat with that. She had not asked Webb to do any of this. She had told him, on the phone, that he didn't owe her anything. He had told her it wasn't her call. He had been right in the way that people were right when they understood that some accountings happened not because the person who deserved them asked for them, but because the people who witnessed them refused to let the record stand uncorrected. "What are you going to do?" she said to Rowan. He looked at her steadily. "I'm going to reject Sandra's filing on the grounds that it is legally insufficient and factually selective," he said. "I'm going to commission a formal review of last night's events by the hospital's Quality and Patient Safety Committee, which will include the testimony of every attending clinician present, every patient outcome record, and the statements from the naval medical personnel." He paused. "That review will take approximately 3 weeks. At the end of it, I expect the record to show what the evidence already shows." "And Sandra?" Emily said. Rowan was quiet for a moment. "Sandra Polk has worked at this hospital for 11 years, he said. "She has been a competent charge nurse in routine conditions. She has also, over a period that I am now reviewing carefully, created a workplace environment in this ER that has cost us at least 4 good nurses in the last 3 years. People who transferred out or resigned, whose exit interviews I went back and read at 5 o'clock this morning." He looked at the desk. "I should have read them sooner. That's on me." He looked up. "She has been placed on administrative leave pending the formal review. If the review finds what I expect it to find, that leave will become permanent." Emily said nothing. She had thought about this moment before. Not often. She wasn't given to running the scenarios of other people's consequences, but she had thought about it. She had thought about what it would feel like when the accounting came for Sandra's particular brand of managed diminishment, the kind that was always deniable and always present and always had a pleasant face on top. It didn't feel the way she'd expected. It didn't feel like satisfaction, not exactly. It felt more like a weight she hadn't consciously been carrying becoming noticeable by its absence, a pressure she'd normalized that was suddenly gone. "There's one more thing," Rowan said. He reached into the desk drawer and put a folder on the desk next to Sandra's document, a much thinner folder. "I'd like to offer you the senior trauma coordination role in this ER. It's a position that has been unfilled for 18 months because I haven't found the right person." He looked at her. "I found the right person 11 weeks ago and managed it poorly. I'm trying to correct that." She looked at the folder. Senior trauma coordination was not a nursing title. It was a hybrid clinical administrative role that carried physician-level consultation authority within the ER, the kind of position that would let her do what she'd been doing last night. Not as an act of individual judgment exercised against institutional resistance, but as the function she was formally empowered to perform. It was, she recognized, the closest thing to her actual capability that a civilian hospital structure could formally accommodate. "Can I think about it?" she said. "Of course," Rowan said. He pushed the folder toward her. "But I'd appreciate an answer before the end of the week." She picked up the folder. She stood up. She looked at Mercer, who gave her a small nod that meant something she filed without unpacking. She walked out of the office. The ER at 8:20 in the morning had the quality of a place coming off a long night, the accumulated texture of hours of hard use, the cleaning staff moving through the bays, the day shift coming on, and receiving handoffs from the night team, the particular kind of quiet that wasn't absence of sound, but absence of the specific intensity that had driven the sound for the last 14 hours. She walked through it. She noted the bays, the positions, the patients she could still see in their rooms. Petrovos had been upgraded to stable in the ICU at 6. Damien Ward's chart showed a temperature of 37.8 and a urine output that had responded well to the fluid management, which meant his kidneys were holding. Dr. Nora Webb had been admitted for observation with an orthopedic consult on the ankle fracture scheduled for 10. She paused outside Bay 4 where Ward had been. The bed was stripped now, clean, waiting. She looked at it for a moment, the blank pragmatic functionality of a hospital bed between patients, and thought about the young man who had been in it and the cooling towers he'd been near and the report that Dr. Nora Webb had put in writing that nobody had acted on fast enough. She thought about what it cost when the people who knew the right things couldn't make themselves heard, how the cost didn't fall on the people who hadn't listened. It fell on the Damien Wards, the people in the way of decisions they weren't part of. She had been one of those people for 11 weeks. She had absorbed the cost of it in inventory shifts and break room silences, and a formal complaint she'd known was coming before it arrived. And she had kept working anyway, not because she was exceptional, because the work was in front of her and she was the one who knew how to do it. And the alternative was that it didn't get done. That was the part that nobody saw, she thought. Not the procedures. Those were visible, dramatic, the kind of thing that generated commendations and formal reviews. The invisible part was the daily decision to keep showing up and keep being capable in a room that was actively organized around the premise that she wasn't. That was the harder thing. That was the thing that didn't make reports. Alicia appeared beside her. "How's your arm?" she said. "Better," Emily said. "Still stiff." Alicia looked at the empty bay. Then she looked at Emily. "Sandra's not coming in," she said. "Word went around about 20 minutes ago. Admin leave." "I know." "Lowe told me," Alicia said, "about the Rowan meeting, about the offer." She paused. "He also said, and I'm just passing this along because it surprised me, he said you should take it. The role. He said it like he meant it." Emily looked at her. "When did he say that?" "About 10 minutes ago. He was at the charge desk doing his notes, and he said it out of nowhere, and then he just kept writing." Alicia shrugged. "Lowe thing." Emily thought about Lowe, about the specific trajectory of a man who was technically excellent and interpersonally difficult, who had spent one night watching someone operate at a level that recalibrated his reference frame. Not humbled, exactly, more like recalibrated. She respected the recalibration. It wasn't easy for people to do. "Okay," she said. "Are you going to take it?" Alicia said. Emily looked at the bay, at the clean, waiting bed. "I'm thinking," she said. She found Lowe at the charge desk, as Alicia had said, writing notes in the focused way he wrote everything, as though the documentation was a problem to be solved rather than a record to be kept. She stood beside him. He didn't stop writing. "I heard you talk to Alicia," she said. "Mm-hmm," he said. "You didn't have to say that." He put down his pen. He looked at her with the direct, slightly uncomfortable attention of a man who had something to say that he hadn't fully worked out how to say. "You were right about the pneumo," he said, "and the tamponade, and the Legionella, and the triage restructure." He picked up his pen, put it down again. "I'm a good surgeon. I know that. But last night I was the second best person in this ER, and I knew it about 2 hours in and kept acting like I didn't." He looked at the desk. "That's on me." "It was a hard night," she said, "for everyone." "Don't do that," he said. Don't smooth it over. It's accurate, and you know it's accurate, and I'd rather you let it be accurate." She looked at him. "Okay," she said. "Okay," he said, and picked up his pen and went back to writing. She stood there for a moment longer than was necessary, because she was aware that this was a thing that didn't happen often. A person with institutional power acknowledging a specific deficit without making the acknowledgement about themselves. And she wanted to register it properly before she moved on. She moved on. Dr. Nora Webb's room was on the 3rd floor, in the short-stay observation unit. Emily took the stairs because the elevator had a specific slowness that she didn't have patience for this morning, and she came into the corridor with the slightly too deliberate stride of a person who was more tired than they were letting their body admit. Webb was awake. Her ankle was elevated, wrapped in the temporary splint the orthopedic resident had applied at 6 in the morning, and she had a color that she hadn't had the night before. Still pale, still worn, but present in the way that people became present when the crisis part was over and the body started reinvesting in the things it had suspended during the emergency. She looked at Emily when she came in. "You look terrible," she said. "You're not far off," Emily said. She sat in the chair beside the bed. Webb looked at her with the clinical assessment of someone whose professional habit was reading bodies for information. "Your arm," she said. "It's fine. Circulation's back." "Did you warm it properly?" "Yes." "Did you sleep?" "No." Webb accepted this without comment, which Emily appreciated. She had been around enough medical people to know the ones who would lecture and the ones who understood that the person who had just come off a night like that didn't need the lecture. "My brother called me," Webb said, "an hour ago. Rask is out of surgery. They're saying full recovery, 4 to 6 weeks." Emily absorbed that. It landed quietly, not with the dramatic relief of a climax, but with the specific low-grade warmth of a thing resolved. Joel Rask was going to be all right. The needle she'd placed in a darkened bay during a blizzard had bought him the hours he needed to get to the people who could fix what the needle couldn't. That was all it had needed to do. "Good," she said. "Marcus also told me what he sent to Rowan," Webb said. "He told me about the commendation and the statements. He asked if I wanted to sign on to the formal version." She paused. "I told him I already had." Emily looked at her. "You didn't have to." "You identified a Legionella outbreak in a symptomatic patient in the middle of a mass casualty event," Webb said. "Based on a field assessment and a fingertip color. My written recommendation to pull the convoy from the mill site was 4 days old by the time they actually moved, and Ward was already symptomatic for 2 days of that." Her voice was even, but there was something in it. The specific compression of a person who had been carrying something that hadn't been their fault, but had landed in their hands anyway. "He should have been out of there before he got sick. My report should have moved faster. What I can do now is make sure the record shows every person who did their job correctly." She looked at Emily. "You did your job correctly." "So did you," Emily said. "The report you filed matters. It's going to matter for whoever goes to that site next." Webb was quiet for a moment. "That's the work," she said. It wasn't self-consoling. It was just accurate. The way people in certain fields said things when they had moved past the point of needing the statement to feel better and had arrived at the point of needing it to simply be true. "That's the work," Emily agreed. They sat for a moment in the particular companionship of 2 women in a hospital room who had both spent the previous night doing hard things and were now sitting in the aftermath, which was its own kind of hard. "The role Rowan offered you," Webb said. "Marcus mentioned it." "Marcus seems to have mentioned a lot of things," Emily said. "He's thorough. It's annoying." Webb almost smiled. "Are you going to take it?" Emily looked at the window. Outside, the morning had come in gray and cold, the blizzard finally done. The sky, the flat white of a front that had moved through and left the aftermath. Cleared roads and heavy snow and the quality of light that came after a long storm, particular and clean. She thought about the question. She had come to Harwick Regional to be quiet, to do work that didn't cost the way the other work had cost. She had been trying, in a sense, to be a smaller version of herself. Not out of shame or defeat, but out of the genuine need to recover the parts that 8 years of high-stakes medicine in hard places had worn thin. What she had found instead was that there was no smaller version, that she could assign herself the inventory and the paperwork and the wrong shifts, and the capability was still there, unchanged, and the moment the room needed it, it acted. Not out of heroism, not out of ambition, but out of the simple fact that she knew what to do and someone was going to die if she didn't do it. You couldn't choose to be less than what you were. You could only choose what you did with it. "Yeah," she said. "I think I am." Webb nodded. "Good," she said. "This hospital needs someone who actually knows what they're doing making the calls." "It has Lowe," Emily said. "Lowe needs someone to keep up with him," Webb said. "He knows it. He just took until last night to admit it." Emily stood up. Her back registered the change in position with the specific reproachfulness of a body that had been ignored for too many hours. She ignored it back. "Get some sleep," she said to Webb. "You too," Webb said. Eventually. She went back to the ER, not because she was scheduled, not because anyone was expecting her. She went back because it was where she was. And the day shift had come on, but the transition was still happening, and she wanted to see it through to the actual end rather than leaving in the administrative middle of things. Lowe was at the charge desk. Troy was doing equipment checks with the same careful thoroughness she'd observed all night. Alicia was briefing the incoming day charge nurse, a woman named Bev who had been doing this job for 20 years and had the specific unhurried competence of someone who didn't need to perform their capability because it was evident. Bev looked at Emily when she came in. She'd clearly been briefed. The nature of a hospital was that everyone was always already briefed. "You were here all night," Bev said. "Yes." "Go home," Bev said, not unkindly, just as a statement of fact with which she expected compliance. Emily almost said she needed to finish something. She looked around the ER, at the bays, the patients, the morning light coming through the windows at the angle that meant the day had actually started, and she realized she didn't need to finish anything. It was finished, not perfectly, not without cost, but it was done, and it was done correctly, and the people who should be alive were alive, and the people who had been wrong about something important now knew they had been wrong. That was all a night could be. She picked up her jacket from the locker room. She put on her coat. She stood at her locker for a moment and looked at the dog tags on their chain, which she had put in her locker rather than around her neck at some point in the last hour, because she had needed both hands and had not put them back. She picked them up. She held them for a moment. The weight of them, the worn edges, the way the metal had taken on the temperature of the locker and was now cold in her palm. She thought about the person she'd been when she first got them. 21 years old, newly rated, about to go somewhere that would change the way she thought about almost everything. She thought about the 3 deployments and the things she'd done in them and the things she'd seen, and she thought about the exhaustion that had brought her to Duluth, trying to be smaller. She thought about last night. She thought about a woman who'd come through an ER doorway 11 weeks ago and kept her head down and done the inventory and absorbed the diminishment and kept showing up every shift because the work was in front of her, and she was the one who knew how to do it. That woman had not been defeated. She had been waiting. Not even waiting, really. She had been working in the only way she knew how to work, which was completely and without exception, regardless of whether anyone in the room recognized it. And then the room had needed it, and she had given it, and the room had changed. She put the dog tags back on. She closed the locker. She walked out of Harwick Regional into the February morning, into the cold that came off Lake Superior and smelled like water and ice and something that was not quite winter anymore. The faint specific shift in the air that happened before anything else changed, before the temperature moved or the snow melted or the light adjusted, the smell of a thing that had decided to become something else. Her car was in the far lot, under 6 inches of new snow. She brushed it off with the scraper she kept in the back seat, methodically, starting at the windshield and working around to the rear window, her breath clouding in the cold and her right arm stiff but functional, and her feet finally, genuinely warm after a night that had done its best to make them otherwise. She got in. She sat for a moment while the engine warmed up, looking at the hospital through the windshield, at the building that had been trying to make her small for 11 weeks and had not managed it, and at the windows that she would come back through tomorrow with a different title and the same capabilities she'd had all along and the institutional authority to use it. She thought about Sandra's folder, with its careful documentation of friction and overreach. She thought about the attorney called at 2 a.m, the 12-page document, the preemptive narrative. She thought about what it said about the kind of fear that lived inside certain kinds of authority, the fear that was not about patient safety or institutional liability, but about the specific terror of being in a room with someone more capable than you and not being able to make them stop. She had not been trying to make anyone afraid. She had not been trying to make anyone look small. She had been trying to keep people alive, and she had kept them alive, and in doing so she had made visible a truth that the room had been organized to obscure, that the person they had assigned the inventory was the person the room needed most. That was not her victory. That was just what was true. But it was true now in a way that was documented and witnessed and carried by people with rank and credentials and the kind of institutional weight that could not be quietly filed in a complaint folder and set aside. It was true in a way that was going to be harder to contain than Sandra Polk had anticipated when she'd made her calculations at 2 in the morning. She pulled out of the parking lot. The road was clear enough. The snowplows had been through, and the post-blizzard light had a brightness that made the white surfaces almost painful. She drove toward home through a Duluth that was quiet in the specific, exhausted way of a city after a long storm. The streets cleaner than they'd been the day before and colder than they'd need to be before spring, but marked by the particular stillness of a place that had been through something hard and was still standing. Her phone buzzed. She pulled over, checked it. Text from a number she now recognized. Rask is awake. First thing he said was to find out the name of the nurse. We told him. He said to tell her thank you. Webb. She looked at the text for a moment. Then she put the phone in her jacket pocket and drove. There was a particular kind of person who went through the world doing the right thing without asking whether the right thing would be recognized, and they were not, as stories often suggested, immune to the cost of being unseen. It cost them. Every day of being assigned the work that didn't matter because someone had decided they didn't matter. That cost something real, and it accumulated, and pretending otherwise was its own kind of dishonesty. What was also true was that the cost didn't change the work, didn't change what they knew or what they could do, or the fact that when the room needed it, they were there and they were ready, and the people who had been so certain. They were nothing stood in the wreckage of that certainty and had to find a new way to understand what they'd been looking at. Emily Hart had not become something different in one night. She had simply stopped being careful about being seen. And in a hospital that had spent 11 weeks looking through her, looking past her, organizing the schedule around the comfortable fiction that she was ordinary. In that hospital, in one February night, everything had looked. She drove through the white and quiet morning, past the frozen edge of the lake that was dark and moving under a pale sky. And she did not feel like a hero, and she did not feel like a victim, and she did not feel like a symbol of anything. She felt like a woman who knew what she was capable of and had stopped apologizing for it. That was enough. That had always been enough. The kind of strength that never announces itself doesn't become real the moment it's recognized. It was real all along. Every inventory shift, every ignored recommendation, every break room silence. It was real through all of it. Recognition doesn't create the thing. It only reveals what was already there, waiting without impatience, doing the work, keeping people alive. In the end, that's the only kind of strength that matters. Not the kind that needs the room to see it to know it's there. The kind that keeps